Surely, this webinar will help us upgrade our knowledge and strengthen our bonds. I congratulate and appreciate the efforts taken by Dr. Nitin Pratap and Dr. Ravi Rajan for organizing this webinar. I'm sure we can conduct many more in the future also. COVID-19 has surely changed the way we practice, especially our sterilization protocols. It is a change in a positive way. Oral surgery is our bread and butter. Today's topic is everyday oral surgery. Our faculty is Dr. Akhilesh Prathap, Associate Professor in the Department of Oral and Maxillofacial Surgery, Pushperi College of Dental Sciences. I am proud to say that Dr. Akhilesh is a member and immediate past president of IDA Tiruvalla branch. He is a good teacher and a clinician as well. I am sure today's class will be helpful to all. On behalf of all the members of IDA, CKK, IDA Tiruvalla, and all those who are present here, I welcome you, Doctor, to this webinar. I welcome our co-host, IDA CKK, President Dr. Anigesh P., Secretary Dr. Nitin Joseph, CD Representative Dr. Nitin Pratap, and all the members of CKK to this class. I also welcome IDA Tiruvalla Secretary Dr. Thomas Jacob, CD Rep, Dr. Ravi Rajan, and all the members of IDA Tiruvalla to this session. We have members from other branches and abroad also attending this webinar. I welcome you all to this session. This webinar, besides on the Zoom channel, can be viewed live on IDA Tiruvalla YouTube channel. Those who are not able to log into Zoom can go on our YouTube channel, IDA Tiruvalla. A few instructions before we start. Please keep your audio muted. Doubts will be cleared at the end of the session. In case of any difficulty, use the chat box. Thank you. Now I request Dr. Ravi Rajan to introduce the faculty.
Thank you, sir. Good morning, everyone. I'll be proceeding into my job of introducing the faculty of today's webinar. Dr. Akhilesh Prathap, he has done his BDS from RV Dental College and MDS from Raja Mutaya Dental College. He has done his MBA from Annamalai University and is pursuing his postgraduate diploma in medical law and ethics from the National University of Advanced Legal Studies, Kochi. He is a fellow of International Board of Oral and Maxillofacial Surgeon. He was the editor of IDEA Tiruvalla Journal and also the AOMSI State Journal. He is the immediate past president of IDEA Tiruvalla branch and the joint secretary of Association of Maxillofacial Surgeons India, Kerala State. He is a reviewer of AOMSI National Journal and Kerala State Dental Journal. Currently, he is working as associate professor in Pushperi College of Dental Sciences, Department of Oral and Maxillofacial Surgery, and consultant maxillofacial surgeon in Pushperi Medical College. He is married to Dr. Subbalakshmi, reader, Department of Pedodontics, Pushperi College of Dental Sciences. On behalf of IDA Tiruvalla and CKK, I welcome you, sir, for the webinar.
Okay.
Akhilesh, sir.
Good morning, everyone. Can I start?
Yeah,
Yes,
sure.
sir.
Yeah, we'll start.
Okay. So my topic for today is everyday oral surgery. So when I start this topic, the first thing that comes to mind is I'm speaking to a, am I audible?
Yes, sir.
Okay, so I'm speaking to a mixed audience. What should I present for them? So today's talk will be based on evidence. So that is the new fad. Evidence is the new fad. I would say it is going to be here for a long time. And you try to base it tried to base it somewhat on my experience. But then some of the talk will be based on logic. But then again, my logic might not appeal to you. So whatever I'm going to present today to you is based on, some of it is based on evidence. But remember that evidence can be falsified. Whatever is presented as evidence today might not hold good tomorrow. And then based on my personal experience or what I have learned from my peers, and some of it based on logic. So any oral surgery talk, I believe, should start with a brief description of the case history. I'm not going into the details of the case history. I only want to highlight some of the things we should be asking from the patient. Something which we all forget to find out from the patient. And especially in these times, it is very relevant to find out a history of fever, whether any hospitalization due to fever or fever which was a symptom of something major, some major other disease, and whatever treatment he has taken for fever. And then about history of hospitalization. History of hospitalization will give you a lot of details about the status of the patient, his physical health, his physical status, his health in the past, in the recent past, and whether he has undergone any surgeries or whether he has got any blood transfusion. These all things should be asked in the case history. And previous history of extractions. We are just assuming that the patient has come to you for an extraction. Always ask the previous history of extraction, whether the extraction was difficult, whether the patient was apprehensive and there was episodes of syncope or something, or there was prolonged bleeding after the extraction. These things should alert you to the procedure you are going to carry out. And something else I want to stress upon is the bisphosphonates calcium supplements. Now, bisphosphonates are a group of drugs which are used by orthopedicians and physicians widely nowadays. This is basically for the treatment of osteoporosis or some bone metabolic disorders, and also for sometimes in bone tumors. Now, bisphosphonates, often for the ease of use, physicians and orthopedicians, they describe them as calcium supplements. The patient might actually give, if you're on any medication, the patient might or might not give you the history of taking calcium supplements, but it is for you to elicit from the patient what exactly they are taking, the nature of the drug, what they are taking in terms of named as calcium supplements. That could be bisphosphonates. Now, there are both oral bisphosphonates and IV bisphosphonates. Now, IV bisphosphonates are more dangerous than oral bisphosphonates in causing osteonecrosis of the jaws. Please note the term what I am using. It is osteonecrosis of the jaws. The findings will be similar to that of osteoradionecrosis, but there is no radiation involved here. It is only because of the anti-resorptive medication or the bisphosphonates what the patient has taken. And if the patient undergoes surgery or extraction, there can be osteonecrosis with exposed bone and necrotic bone, which might manifest. Now, we might get confused. The differential diagnosis includes dry socket. It is very common for us to misdiagnose this as dry socket if you are not elicited a proper history, and then you might treat it for dry socket and the bone would refuse to heal, or the soft tissue would refuse to heal. So always keep this in mind, especially individuals who are more prone to osteoporosis, middle-aged ladies who are in their old age. Such people are more prone to be placed on supplemental bisphosphonate therapy, and always elicit a proper history from them. Now, taking medical history, this is based from my experience. Always, when you are asking about their medical history, do not ask, do you have BP? Always ask, have you ever had BP? Now, there are some patients who are in the habit of taking anti-hypertensive medications for some period of time, and then the BP comes back to normal, and then they stop the medication. Most of the times, the hypertensive medications are to be taken lifelong. It is not just for a few days or weeks, most of the times. Okay. So always phrase it like, have you ever had BP? And then again, history of heart ailment, surgeries, all these things also should be recorded, because the surgery would have been a coronary artery bypass graft or a angioplasty. All these things would have been done long back, maybe 5 years back, 10 years back, but that is still relevant. Or the patient would have undergone a closure, valve defect closure or something like that, valve replacement, things like that. Probably he's functioning normally. He is able to do all the activities normal. He might not consider it significant, but it is for you to elicit the history from the patient. And epilepsy and asthma might be childhood diseases in some patients. Whenever you are treating a patient, make sure that you have to ask about the history of epilepsy and asthma. Epilepsy even more important because he can undergo a seizure attack in the chair. And most of the times, people who are on regular medication, epilepsy will not get an attack. But people who discontinue the medication, in the habit of discontinuing their medication, they might end up with a seizure attack. And also, regular medication, and history of past medication. Have you taken any medication? All these things should be included in your medical history. I'll just look at some of the important diseases. We'll just look at some of the important diseases which we have to deal with in daily life, daily practice. First one is diabetes. Most of the times we send for an FBS, a fasting blood sugar, whenever we are doing, and some of us we send for both FBS and PPBS. I'm not saying it is wrong, but never send for FBS alone to know the glycemic control. The reason being, it is a fasting fasting blood sugar level. The patient can fast overnight. Many people have that habit. You know, you fast on the previous night, or you cut down your food intake by half because you are going for a blood test next day morning, and then you get a result which is pretty normal. And don't forget that there is got something like 8 hours of fasting to get his blood sugar levels under control. Always check a postprandial blood sugar, or check a glucometer. GRBS is glucometer, random blood sugar. Now, I do not always do extractions when it is well within 140 milligrams per deciliter or 160 milligrams per deciliter. I have kept the cutoff of 200 milligrams deciliter, which has been recommended by some, which is prescribed in some textbooks also. So I consider it safe to do an extraction if the patient's blood sugar value is below 200 milligrams per deciliter. And then for a well-controlled diabetic patients, it is not necessary to prescribe antibiotics if it is well-controlled. But then if it is not so well-controlled, maybe it is safer to prescribe some antibiotics. And if you have a physician's consent, that is the blood sugar levels, some people have such huge variations in their blood sugar levels, such people is sent for a physician's consent. And then if the physician tells you to do, you can even do it with about 250 milligrams per deciliter, less than 250 milligrams per deciliter also, it is okay to do it. The next one is hypertension. What is normal blood pressure? We were taught in our undergraduate days, we were taught as normal blood pressure is 120 by 80. It's no longer, it's all true. It is something less than 115 by 75. So that is considered normal nowadays. So, but is that possible to attain such a blood pressure when you're doing some elective procedures? Most of the patients who come to your dental clinic will be having a blood pressure of more than 115 by 75 or more than 120 by 80. A normal, much more long, normal BP would be something like 140 by 90. So where do we keep the cutoff? We keep the cutoff. I personally like to do extractions when the patient's BP is below 160 by 90. And some cases it is okay, even if it is something like 170 by 90. Remember, each local anesthesia, each cartridge of local anesthesia can increase your systolic and diastolic blood pressure by 10 mm. So keep it as 160 by 90. And then you can go up to 170 by 90 also in some cases. And also be aware of white coat hypertension and extraction anxiety. How do you rule out extraction anxiety? If the patient comes, you take at least 2 readings of blood pressure. And then if both readings are high, you postpone the extraction. But don't recall him on another day. Ask him to visit a nearby hospital or a doctor in the evening or some other time and ask him to get his BP checked again. If the BP values are normal, then that means he is suffering from extraction anxiety, and you can probably prescribe some anxiolytic for him. My personal choice is I prescribe tablet alprazolam and 0.25 mg. I don't give it on the day of extraction. I ask him to take it one day previously before sleeping. So that will give some amount of anxiolysis for the patient. And in case he goes to some physician and he finds his BP is still high, then it is time for him to start his medication, anti-hypertensive medication. Now, hypothyroid versus hyperthyroid. It's very difficult to find out the patient is hypothyroid or hyperthyroid. Most of the hypothyroid patients look like this. Middle-aged ladies or even young people can get. Most of the time, the hypothyroid patients look like this. And then it's very, very rarely you will get a typical hyperthyroid appearance in the patient. And most of the times, your patients are confused whether they are having hypothyroid or hyperthyroid. So you ask about the medication. These are the commonly prescribed medications for thyroid conditions. L-troxin, thyroxine, these are all prescribed. These are all thyroid supplements which are prescribed for hypothyroid conditions. And propyl thiouracil and carbimazole are prescribed. when the patient is having hyperthyroidism. The only thing that you should remember in hyperthyroid patient is you avoid anxiolytics. You will all be knowing about mixed edema, coma, and thyroid crisis. All these things are extremely rare in a dental setup. You just have to be aware of it. You don't have to refrain from treating the patient because you are worried that something like this might precipitate. But try to avoid anxiolytics in hypothyroid patients. Anxiolytics like barbiturates or something like your alprazolam. Try to avoid such things in hypothyroid patients. The reason being already their metabolism is slow, and if you add a further sedative to it, that might even further depress the metabolism and the patient can go in for a coma. So that is one thing you have to keep in mind regarding hypothyroid patients. And it is still controversial whether you can use adrenaline with LA or you should use plain adrenaline. Personally, I prefer to use all my extractions. I prefer to use local anesthesia with adrenaline because it is very, very difficult to get a proper depth of pulpal anesthesia with lignocaine without adrenaline. So try to give lignocaine with adrenaline, but remember to limit the dosage. Now, antiplatelets and anticoagulants. Anticoagulants are also called as blood thinners. Know the difference between antiplatelets and anticoagulants because the mode of action for the conditions for what they are prescribed, they are all different. Now, antiplatelets are basically to prevent platelet aggregation or the formation of a platelet plug. There are not very few tests which can be used for antiplatelets. Yes, you can do the bleeding time. It is not very significant, or you have to get a value about 20 or something for it to be significant in case of antiplatelet drug therapy. We usually send for many people have this habit of sending for INR when we are doing for antiplatelets. It does not show anything. INR is significant only on patients who are taking anticoagulants, that is like warfarin, heparin, or dabigatran. Okay, please be aware of the new kinds of drugs, dabigatran and dipyramidol is also an antiplatelet drug. Be aware of the names at least of drugs. There is nothing wrong. If you find a drug, ask the patient to bring his prescription, look at all the drugs. If you find a drug which is not familiar to you, go on the net and search for it. Find out what that drug. There is nothing wrong. Nobody expects you to know all the drugs and what their actions or drug interactions. Go find out what it is and then proceed for treatment. That might be a blood thin. There are so many new anticoagulants and antiplatelets synthetic types available. We do not know what the physician would have prescribed. Find out what it is at least. Now, all these medical situations, how do you refer to a physician? What are the situations? So you describe the correct procedure. What exactly are you going to do? Don't just send for physical fitness. I need fitness for this patient. Do not send like that. Describe the correct procedure. I am going to extract 3 teeth under local anesthesia. This is going to take me 45 minutes time. I am going to use 2% lignocaine with vasoconstrictor drug concentration, which is very important. Right? If you are going to write 1:1 lakh or 1:2 lakh adrenaline, always mention that. Why? Because the physicians are more familiar with the concept of 1:1000 adrenaline, which is used for emergency purposes or management of anaphylaxis, etc. Now, we are using adrenaline, which is about 1:1 lakh or 1:2 lakh, which is very not at all significant, not very, very little significant. So whether when you're referring the patient, always mention the strength of the vasoconstrictor. If you do not mention this, sometimes the physicians or the cardiologist will send the consent with citing that use a local anesthesia drug without vasoconstrictor. Now you are in soup. If it comes back like that, you are okay. It's just an opinion. You can still use with lignocaine and adrenaline. You can still use, but then again, it will not be very correct to use it like that. And if you do not use vasoconstrictor in your local anesthesia, the patient is definitely going to experience some kind of pain during extraction, which can further complicate things. So always mention vasoconstrictor drug concentration and opinion, whether you need an opinion regarding his status or fitness regarding his physical status. Whether it is just the cardiac status or his general physical status for undergoing the procedure. Always explain that in detail to the physician. And also write about any alteration in medication. This holds good on 2 situations. Now, most of the times the antiplatelet drugs, physicians like to stop the antiplatelet drugs, but remember that it is always safer to continue the antiplatelet drugs. So antiplatelet drugs are basically given because you want to prevent any thromboembolic events, which is a more grievous problem. whether a patient getting a thromboembolic event on your chair or some bleeding, which can be stopped by local measures. It is always better to have some bleeding, post-op bleeding. And many of the times you do not even need, there will not be even prolonged bleeding following the extraction. So if you want quite clearly alteration in medication, and also if the patient has some kind of cardiac condition which requires an infective endocarditis prophylaxis, it is always better to ask the cardiologist what kind of prophylaxis should be given or whether prophylaxis needs to be given. Now, in most of the countries, they are done away with this antibiotic prophylaxis, infective endocarditis prophylaxis for most of the conditions. But one reason for them totally eliminating this is the cost of the medicine there. But here in India, our medicines are relatively cheaper, and then still we follow this, some of the techniques. And there is difference of opinion in physicians itself. Like some follow the American Heart Association and some follow the British Heart Association. Now, American Heart Association like to give 2 grams amoxicillin before the procedure. Sometimes the British Heart Association, they ask for 3 grams of amoxicillin. Now, usually it is okay to ask the physician for opinion regarding this. Am I going too fast? Should I slow down?
It's fine. Carry on.
It's fine, doctor.
Okay, fine. So next one, coming to clinical examination. We all know how to examine a patient. Only suggestion or recommendation I would like to make is use 2 mouth mirrors. Most of the times we have this habit of, using 1 mouth mirror, you retract the cheek and then you try to see the tooth. Use 2 mouth mirrors. Use one for retraction, one for examination. Okay, and also practice this indirect vision, not just for examination. That's why a mirror is there. It is not just for retraction. You can use any retractor for retraction. You don't need a mirror there. And learn to use illumination. Sometimes when you're examining a white spot or you're examining a red lesion, learn to use indirect vision and illumination also using your mouth mirrors. Now, we'll look at some clinical predictors of difficult extractions. As you all know, you must be knowing most of these things, but still I'll just mention them. Age. As age advances, the difficulty of the extraction increases. The loss of crown, tooth which are endodontically treated with limited access. Sometimes it can be due to limited mouth opening or the tooth which is situated in the posterior part of the oral cavity. The buccal bone thickness. As age increases, buccal bone thickness might increase. And the build of the person. This is something which we forget. It is not same. Trying to extract in this patient and trying to do an extraction in this patient, it is not same. You have more flabbier cheek. The retraction will be much more difficult. The bone density will be much more higher. So that is going to make a difference to the difficulty of extraction. Now, is IOPR necessary before imaging? Is IOPR necessary before every extraction? In a standard operating protocol, yes, IOPR is necessary before every extraction, especially if you are doing a 3rd molar extraction because of the variations in the root. It is better to take an IOPR. But I personally believe that only if it is going to be something different from your routine extraction, you need to take an X-ray. So, and if you are in doubt, always take a chest X-ray in between procedure. Okay, you think that the cost of the chest X-ray is going to be 200 rupees or 250 rupees or whatever you are charging, but actual cost is only about 20 rupees or 30 rupees. So if you are in doubt, take a chest X-ray, don't charge, you take a chest X-ray, do not charge it to the patient. And OPG in situations when you feel that the IOPR is not enough, you are only seeing the tooth partially, you are not able to assess the density of the bone. Such situations, take an OPG. I have included lateral cephalogram only for diagnosing canine impactions, not for the orthodontic purpose. So lateral cephalogram is an easy way of telling you whether the canine is placed backly or palatally. It's difficult to make out it from an OPG. Sometimes where there might be no bulge in the vestibule when you palpate. So in such case situations, you can take a lateral cephalogram. It will tell you in relation to the teeth whether the impacted canine is placed laterally, is placed buccally, labially, or it is placed palatally. Now looking at the radiographic predictors, there can be divergent roots, dilacerated roots, slender roots, long roots. There can be increased number of roots, All this will increase the difficulty of extraction. And then, of course, root canal treated. The patient would have forgotten that he's got a root canal treatment done for that. And probably the only a pulpectomy was done and this tooth is brittle. He would say there is no root canal treatment done. Then also look for internal or external resorption. All these things can complicate your surgical procedure. And finally, hypercementosis or bulbous roots. This is always our excuse, right? Hypercementosis. It is very rare, but usually whenever you're faced with a difficult tooth, this is what we run to. This is our shelter. We say it is hypercementosed. But then if the absence of lamina dura is very evident in an IOPR, it is always good to suspect hypercementosis and then proceed to that extraction with little caution. Or maybe you can even directly go for a transcellular extraction. This is something else which you should all think about in doing an extraction. Assess the crown width. Also the mesiodistal width of the roots. If the mesiodistal width of the roots are wider than that of the crown, that means your extraction is going to be difficult. Now, if you are in the habit of using dental elevators for your extraction, this is something else you should warn the patient about. Large fillings in the vicinity. However good you are, sometimes you will end up fracturing that. So to avoid embarrassment, it is always better to tell a patient that adjacent filling might fracture, that might come off, we'll have to do a refilling. Okay, always remember that. So two things to remember, always check for the mesiodistal width of the crown and the mesiodistal width of the roots. And also warn the patient regarding anything like a fractured filling, a large filling, which might be troublesome. Investigations. Whenever you're dealing with an old age patients or patient with some diseases or a patient who does not give a clear history, patient's past is vague. Such cases you should definitely do a blood examination. And I am not very keen on doing routine blood examination for each and every patient that comes for extraction. Routine blood examinations, I don't think it should be routine. And there is no point in doing all the investigations, WBC count, ESR, basophils, eosinophils. Why do you want to know all those things? It is not, 90% of the time, it is not going to give you any diagnosis. It is not of any relevance for you. Maybe you should look at the hemoglobin. You should have a hemoglobin at least 10 grams. The idea is that if it is below 9, you cannot take up the patient for general anesthesia, but then you should get a consent if it is, even for local anesthetic procedures. Find out from a physician if it is okay to proceed with the extraction if it is below 9. Then RBS for obvious reasons. I like to look at platelet counts more than bleeding time and clotting time or things like that. I like to look at platelet counts. If the platelet count is above 1.5 lakhs or 1 or 1.5 lakhs, then I feel it is relatively a safe indicator of whether you can do the extraction. At least some of those platelets are going to function and you are not going to have a troublesome post-operative post-extraction bleeding. And INR, like I told you, only in situations where it is necessary, only if the patient is on anticoagulants or something. Most of these things, even if the INR is high or if there is a variation in your bleeding out protein, still you can stop the bleeding by local measures. So do not waste a lot of patients' money or waste your time doing a lot of investigations. Do only what is necessary, and you should also know the reason why you are doing it. I'm not going to talk about infection control at all. I just want to stress upon avoiding cross-contamination. So you clean your instruments and equipment before you sterilize them. All of us sterilize our instruments, but what we lack is on the cleaning part. Check on your assistants whether they are cleaning it properly. Take the instrument sometimes, just check whether there is any blood clots, because sterilization will not remove all those blood clots and stains on the instruments. It might be sterilized, it might be packed properly. Once you come, the tray comes to you and you open it, you can see a blood stain right on the instrument. Very embarrassing situation. So make sure your instruments are cleaned properly before you send it for sterilization. You need to monitor your dental assistants who is doing that. And every week or every month, you need to go and sit on the dental chair where you treat your patients. You can just, that spittoon itself, you can find out how dirty the spittoon is, or maybe you are cleaning it, but maybe you're not paying attention to. Maybe your assistant is cleaning it, but it are not being done properly. Light handles and light. We all have this habit of adjusting the light during a procedure in a difficult extraction. Everybody does it, I do it. But then it's good to have a sleeve for your light handle. What is the purpose of sterilizing each and every instrument, autoclaving it, and then finally you are using without changing gloves or without cleaning the light handle if you adjust the light? All that sterilization is wasted. So make some autoclavable changeable light sleeve handles. It's even made out of cloth. It is green cloth. It is enough. Put that on your right handle. Use that for every patient. Just keep that, make it part of your tray. Change it for every patient. You can adjust the light in each and every way you want. You don't have to depend on your assistant for that. So try to avoid cross-contamination. Make sure that everything is clean before you send it for sterilization. Before you start the procedure, a little bit about consent. Again, this is something all of us know. But what exactly is informed patient-specific consent? There is implied consent and expressed consent. And most of us use this blanket consent. This is not useful in a court of law, but this can help us. It's not ad memo, it's an aid memo. This can be used as a just to recall for you and the patient to recall all the things that can be discussed. Remember that your blanket consent, printed consent, it is not valid in a court of law. Now, informed consent means you have informed the patient of all the treatment options and also about how you are going to proceed with the treatment and for whatever complications, and the patient has been informed, he has understood about it. And it has to be separate for each patient, preferably handwritten and countersigned by both the patient and the doctor. And implied and express consent. The patient sitting in your dental chair, I always ask the patient, can I examine you? And then I start my procedure. And even if he does not say, even if he just comes and sits in your dental chair, that means he has given an implied consent for you to do the procedure. Now, express consent, shall I remove this tooth? Patient says, yes, please remove that tooth if that is causing the trouble. That is express consent. Now, I'm not sure about how the Indian courts deal with it, but West, even you don't need a written consent as long as the express consent is also sufficient for you to do the procedure. So even if you are using a blanket consent, remember that it is something for you to recall whatever has been discussed. It is not much of it. Is if you are going to do it on a patient who is troublesome, then always take an informed patient-specific consent. Moving on to local anesthesia. Subjective symptoms are those which are explained by the patient, and objective system, there is only one objective, right? Painless procedure. That is why we give local anesthesia. Now, most of us base our extractions or our surgical procedures on subjective symptoms. We tell the patient, is the lip numb, is the tongue numb? Then you start doing the procedure, patient will experience pain. He's saying it is hurting. So have you achieved your objective? No. If the patient is having pain, you're not achieved your objective, stop the procedure, repeat the LA or do whatever you have to do for making it painless. Do not depend on subjective symptoms. Always depend on objectives. Now about topical anesthesia, this is much neglected thing. Many of us do not have this habit of doing, and even then people who come out of dental colleges, even if they are trained to use local anesthesia, topical anesthesia, once they finish college, they immediately stop using this. This is not right. Imagine yourself sitting in that chair. And my personal choice is Precain or mucopain gels. Precain is a bit more expensive, but remember that it contains both contents are amides, which is less reported or no allergy is reported. It contains lidocaine and ibuprofen. So it can be used for your topical anesthesia. Use some topical anesthesia, or mucopain also you can use. It's relatively cheaper. It's more widely available. It contains benzocaine, which is an ester, but you can still use mucopain also for your topical anesthesia. Even mucopain works equally well. Now use one of your choice, but do use one. And you wait for it to act. Just applying and immediately taking the syringe and injecting, then the whole purpose is lost. It might take 3 minutes, depending on the site where you are injecting. It will take some time for the topical anesthesia to act. If you are injecting into the buccal vestibule, fine, it takes 2 minutes for it to act. So if you are applying it on the palate, it will take more time. It will take 3 minutes or 4 minutes. Wait till it acts and then you give. And 2 areas where you should not do local inject without topical anesthesia. One is palatal infiltration, extremely painful, and the other one is the long buccal nerve block. Most of us, before giving inferior alveolar nerve block, might apply topical on the medial surface of ramus and neglect this buccal vestibule or the area where you give your long buccal nerve block. Very wrong. Buccal nerve block injections are much more painful than your medial side injection. And how do you improve your infiltration? It is one is by slow rate of injection, 1 ml per minute. It is a good number to keep in your mind. And always during your infiltration, communicate with the patient. Always try to distract him. We are always taught in dental schools how to establish rapport with the patient, ask his name or ask where he's from, all those things. Try to distract the patient. When you're communicating, try to distract the patient. Do not use the terms like pain or anything. Say discomfort. You will know this, that this is happening, something like that. You will be able to know that. And where to infiltrate based on anatomy. Our target area is the apex of the tooth, right? Where you are trying to give a local infiltration. That is the area where the nerves and the vessels enter into the tooth. You're always trying to inject at the apex. But you should also keep in mind the bony anatomy. For maxillary molars, it is always better to give at the apex or slightly below the apex. Two reasons. One, because the bone is more porous, slightly below the apex of the tooth, especially in the first molar region. If you go at the apex of the first molar tooth, the cortex will be thick. So slightly below the apex also you can inject. Second one, the concavity of the maxilla and the density of the connective tissue. The maxillary tissue tends to be more loose as you go higher up. If you go well beyond the apex, if you go too much beyond the apex, then there is a chance that you will be entering into loose connective tissue and your local anesthesia will diffuse faster. So if you are going just below the apex, the connective tissue is little more dense, and then it is much easier to inject. And always along the long axis of the tooth. This is what we are taught in schools, dental colleges, always along the long axis of the tooth, but it is also okay to give it right angles to your tooth. All these problems, what I mentioned now, can be avoided by giving your maxillary anesthesia by giving it at right angles to the tooth. But remember, when you are giving at the right angles, go hit the bone at the apex. Remember to retract it by 1 mm, aspirate and inject. Why? You don't want to give a subperiosteal injection. You want only your injections to be supraperiosteal. Maximum failures in our practice occurs in inferior alar nerve block, right? About 15 to 20% of the time we fail. There are multiple reasons. One of the reasons is operator error or the anatomical variations, or you're not accurately determining the mandibular foramen. Many reasons for our local anesthesia to fail. I just want to explain this arch needle technique to you, which I have found very useful. I use it a lot in my practice. Just bend the needle, give the needle a gradual curvature. Do not give an acute bend. Then you'll end up kinking the needle, and chances of fracture will be more, or breakage of the needle will be more. Give a gradual bend like this on the needle, and use your same landmark, same technique. Go from the opposite side premolar. So this will help you to overcome the curvature of the anterior ramus or the thick part of the ramus. It will help you to bypass the thickness of the medial surface of the ramus, and then you will be able to inject the solution into the mandibular foramen region. And then after aspiration, you inject about 1 ml, bring it to the same side, and aspirate and inject again. Even if you don't do that, lingual nerve is taken care of in a curve technique. And then finally, you can use for a buccal nerve block. Try this technique. It's not very difficult to master this technique. This is something else which I have found very useful. And people who do transmolar extractions or third molar surgeries, they know. You are given your block, you are reflected your mucoperiosteum, you have started bone guttering, all that went fine. You try to start luxating the tooth. Patient experiences pain. So can you see these little perforations? Once you are reached beyond, you have crossed the cortex and you are gone into the marrow or the cancellous bone, you can see all these perforations. You can inject one drop into all those perforations. This will give you profound anesthesia. I call this is not a scientific term or something. I call this walking the needle. You start from the mesial side, you slowly inject little by little, drop by drop, and into the posterior part, till wherever you are gutted your bone, inject into the marrow. Can you see this area? Can you see that it is very close to the pulp? Use a stout needle, go into the pulp, give an intrapulpal there. This will also help you to reduce the pain in luxation and also for removing the tooth. Another technique, you might be familiar with go gates and both Vasarani Akinosi. Go gates is a very difficult technique to master, and it is very difficult to give it properly. In spite of giving it properly, it might not work, and the patient also has to cooperate fully, wide opening mouth. Now, this is a relatively easy technique. This Vasarani Akinosi block or a closed mouth technique is a relatively easy technique for you to master. You just go, ask the patient to close the mouth. You can fully close or close it by half. Insert the needle into the medial surface just above the occlusal plane. It goes above the occlusal plane of maxilla. Insert into the medial surface of the ramus, aspirate and inject. Okay. Make contact with the bone, retract by 1 mm, aspirate and inject. You can give a slight curvature of the needle here also. That's called Wolf modification. Even for Vasarani Akinosi, you can give a slight curvature of the needle, aspirate and inject. This Vasarani Akinosi is a very good technique if you have post-operative trismus. You want to help the patient with mouth opening exercises. Or if the patient has got a very limited mouth opening. Such situations you can give, you'll not be able to appreciate the landmarks for inferior nerve block. Use this Vasarani Akinosi technique. Now, local anesthesia without adrenaline, your lignocaine, 2% lignocaine without adrenaline. It is used in inflamed or infected tissues. It is based on the pH of the tissue. Inflamed tissue is more acidic in nature, and then lignocaine with adrenaline might not work. So use lignocaine without adrenaline. One of the techniques I use is for mandibular teeth which are infected, even in spite of giving antibiotics and things like that, or something known as hot tooth, which are hot teeth are basically teeth with chronic irreversible pulpitis. Such patients, you can give a nerve block for inferior alveolar. You can give an inferior alveolar nerve block with adrenaline, your normal lignocaine with adrenaline. And then you infiltrate around the tooth with plain LA, infiltrate into the buccal tissue, go give some lingual infiltration. You can even give some periodontal ligament injection, all these things. Now, this will reduce the pain considerably. So you keep a bottle of lignocaine without adrenaline in your clinic, refrigerate it and keep it. You will not need to use it every day. Now, this I feel is only indication for using local anesthesia without adrenaline, only in situation the tooth is infected or inflamed. For all the other situations, except hyperthyroidism and for conditions like some cardiac conditions, it is safe to use lignocaine with adrenaline. Even in such cardiac conditions and hyperthyroid patients, it is okay to use lignocaine with adrenaline as long as you limit the number of cartridges or number of syringes of solution you are going to use. Okay, for those who are not familiar with this one, this is Artichain is also a local anesthetic drug. It is a very good local anesthetic drug. It is got slightly more strength than it is lignocaine. What we use is 2%. Artichain is 4%. But Artichain, I am not sure whether it is available in blow bottles. It is only available as cartridges. Even if you are not using a self-aspirating syringe or something like, you can just take the solution from the cartridge and use it on your patient. It will give a greater depth of anesthesia compared to lignocaine. I basically use it only for infiltrations because of the higher concentration, because 4% Artichain. Now, this can lead to some nerve paresthesia. If you give a block with Artichain, there are some reported cases of nerve paresthesia following Artichain injection. And another very good reason for using Artichain, especially in young patients, most of the times you have to give buccal infiltration and palatal infiltration for doing a maxillary molar teeth extraction, right? But when you are using Artichain, the solution is such that the structure of the molecular structure is such that it can diffuse onto the palatal side. That means you just have to infiltrate on the buccal side. The palatal side also gets anesthetized. You don't have to give a separate palatal injection, which is painful in most cases. That is one of the advantages of using Artichain. But try not to give any nerve blocks, especially inferior alveolar nerve block, using a Artichain solution. We look at some simple extractions. I don't know who used the term simple extraction. Extractions are never simple. You never know what is going to happen. So very basic things I am going to tell you here. In case you have forgotten it from your dental college days, your study days, reflect the mucoperiosteum as one layer. It has to be separated as one layer. The periosteum has to, as soon as you reflect the mucoperiosteal layer, what you're seeing is, should be able to see the bone, not the periosteum. Reflect it as one layer. And elevate from papilla to papilla. Never start at the center of the tooth. You don't start reflecting from here. You have to start at the papilla. You start from one papilla, go to the opposite side papilla. And how do you do it? You use the sharp end of the periosteal elevator. That motion is called prying motion. I can show you, I can describe that motion. It is called prying motion. So you start your elevation from papilla to papilla using a prying motion of the sharp tip of your periosteal elevator. And once you have done that, for further reflection, change the side. Most of us don't do this. We don't even know what is that blunt side there for. Not much use for. Usually we use it for retraction. So use the broad blunt tip after that. Once you have used your sharp tip for prying motion, and if you have made the initial reflection, use the blunt side for further reflection. Why? Sometimes if the flap, mucoperiosteal flap, if it is thin, you will end up perforating. You'll perforate the mucoperiosteum. You'll buttonhole it. So use the blend, and once you have cleared the initial papillary reflection, use the blend and for further reflection. Now, about tooth luxation, the first point is something which we all forget: apical force. Don't start with buccal or don't start with lingual or rotational forces. Always push upwards or downwards. Apical force is the first force that you should give. And always give buccal force, because buccal bone is thick on mandible, buccal bone is thick on maxilla, relatively thicker on maxilla. So always use a buccal force first. So for extraction of maxillary teeth, you can use strong buccal and strong palatal forceps. Why? Because bone is strong. Most of the times bone is strong on both sides, both buccal and palatal sides. And for mandibular teeth, you give strong buccal but weak lingual forces. Why? The lingual cortex is relatively thin, so you don't need to apply much force in that direction. Sometimes the path of exit might be on the lingual side. Keep that also in mind. And another mistake we all make is using lower anterior forces for a lower canine. See, width of the lower canine is more similar to that of a premolar than that of a lower central incisor or lateral incisor. But since we are doing an anterior tooth extraction, we always reach for the lower anterior tooth forceps. No, use a lower premolar forceps for lower canine extraction. That will give you a much better grip. That will give you a much better contact. Now, a few things. If in patients with very thin patients with very thin mandible, when you are doing this buccolingual forceps, when you are using buccolingual forceps, the patient will have severe TMJ pain. The area of procedure is relatively pain-free, but you will have severe pain on your buccolingual rotation. That is because the TMJ is also moving. How do you get over that? Use your non-dominant hand properly. Non-dominant hand means the hand which if you're a right-handed operator, your left hand is your non-dominant hand. Okay, so support the mandible properly. Ask the patient to close them. It is not always necessary to visualize what you are doing. Contrary to the belief, if you're only going to, if you have applied your forceps correctly, then you can ask the patient to close the mouth by half. And you can use a slight figure of 8 motion, slight motion, a little more than the last. Slowly increase the figure of 8 motion. Don't do it a big figure of 8 motion, you'll fracture the tooth. So this is one way of avoiding pain in the TMJ when you are doing a lower mandibular molar extraction. And support the mandible properly. Your thumb should be in the buccal vestibule, or your forefinger should be in the buccal vestibule, supporting the alveolus. Your thumb should be on the lingual side, supporting the lingual cortex. And all the rest of the fingers, it should be supporting your mandible. Try to avoid moving the mandible. Just try to luxate the tooth by that. And you can also use a figure of 8 motion. I wish I could show you how to do it, but this is something which comes with practice. And also keeping the mouth at half closed position, that will take out a lot of strain from the temporomandibular joint. Expand the socket rather than trying to pull out the tooth. Your aim is to, that is the final result. Pulling out the tooth is the final. You should not even say pulling out the tooth, removing the tooth. Okay, it is a final result. Try to expand the socket, bony socket, by using your forceps. Use the tooth and try to expand the socket. The tooth comes out by itself. That is what you do by luxation. You're not trying to pull out the tooth. You're trying to expand the socket. Keep that in mind. Now we have done the extraction, the simple extractions. We'll just go discuss some sutures. Most of us are very unfamiliar with what to use. We all buy whatever is available with the supplier. We just buy that and we use it. And try to make an atraumatic note. I will speak more about making an atraumatic suture. But this is the standard prescription. 3x8 circle. What you see here is a 3x8 circle suture needle and a half circle. This is a 5x8 circle. So ideally, you should be using a 3/8 circle for anteriors and a 5/8 circle for posteriors. This is because of that curvature. This is the ideal curvature for going in the anterior sockets, and this is ideal curvature for this got a slightly more curvature, so it is easier for you to do the posterior too. But then you can work on all the teeth. Even if you have a 5/8 circle, it is sufficient for both anteriors and posteriors. And what size needle to use? Use sizes from 17 to 19. Okay, this is the size of the suture needle I am talking about. Use sizes from 17 to 19. This is ideal for a 6-inch long needle holder. If your needle holder is going to be shorter or longer, then you should change your needle sizes because the grip will not be proper. So for a 6-inch long needle holder, which is the ideal length of the needle holder, what you should use in oral surgery, use the sizes from 17 to 19. Excuse me. Now, this is how you make a traumatic knot. This is from a very old textbook called Laskin. Some of you would have read this in your undergraduate studies. You would have seen the picture and forgot all about this. Do not make a very tight knot. Okay. So this is one of the techniques. You can see how the threading is done. So take the loop, make a loop, take it over the needle, bring it back, and see, this is the most traumatic knot you can do it in an eye needle. Or if you want a knot which is not at all traumatic, you have to go for a swage needle, which means the suture is attached to the posterior part of the needle. Okay, so this is how you make an traumatic. Look at the picture again, maybe take a screenshot, try to use this. Have you experienced this? Now I'm telling you that now next time when you do it, you will experience. If you have a large knot in your suture, what you're using for suturing, this is how you will pull the patient forward. Okay, you can feel that jerk. You can feel that movement if you are using a traumatic suture. Now, round versus cutting needles, probably not much significance when you're doing a socket suturing, but round body is less traumatic, tissue tear is less, but you need to apply some force and also restrict it only for suturing in thin and fragile tissue. Now, the cutting needle penetrates better. Use it for thick tissue. Be gentle or it will result in tissue damage. So it is written on the suture packet itself, whether it is round body or cutting body. Sometimes you are finding it difficult to penetrate tissue because you are using a round body. So wherever you are here to deal with cutting needles, for all extraction sockets, use a cutting needle. So this is another suture. We all put interrupted sutures, but this is another technique for suturing. This is something which we all should master. You start from the distobuccal, you come to the mesiobuccal, the mesiolingual, then you go back to the mesiobuccal, and then you come out. This is figure of 8 suturing. You come out through the distobuccal and then you tie the knot. This is called figure of 8 suture. You want me to repeat that? Just remember where you're, just remember where you're starting the suture. You're starting at the distobuccal area. Okay. So the tooth has been extracted, first molar has been extracted. Start at the distobuccal, come to the opposite side, you come to the mesiolingual. From there you go to the mesiobuccal, then you come out through the distolingual and then you tie the knot. There are different methods of doing this figure of 8. This is only one method. Basically, the idea is to make an X inside the socket. Why? If you have a socket which is going to bleed, or if you are doing surgery extraction for a patient who is on blood thinner therapy, this is the ideal suturing technique to use. So you can pack in an abgel also inside the socket. This will help you to pack in an abgel. It will hold the abgel in position. Now about distal molar suturing. Just want to stress upon this suture, this particular suture. Whenever you are doing a last tooth extraction, whether it is second molar or first molar or third molar, you have done a third molar extraction and you want to put a suture, place this suture as close as possible to the second molar. Don't leave a gap here because this will prevent periodontal pocket formation. This is very important. What happens is there is no tooth there. We are taking out the third molar. And what happens is this tooth, if the healing is not proper, there can be periodontal pockets here, or this tooth can start inclining distally, which means you will be creating a gap here with more food abduction, and ultimately the second molar also will go for a toss. So try to do this suturing as close as possible to the periosteum, as close as possible to the distal side of second molar. Now, how to remove a suture? You should have an SOP for this. Don't just cut or use a blunt scissors to remove. This will end up being more painful and uncomfortable for the patient than doing the actual extraction itself. Okay, first step is to do is irrigate and remove all the debris. If you're recalling the patient after 1 week, remember that there will be a lot of debris which would have collected over the suture. And then irrigate and debris, or when you're pulling out the suture, all that debris is going to go inside the suture tract. Use a topical spray. Never do a suture removal without using a topical spray. That gesture matters a lot to the patient. Use a spray or use a gel if you don't have time for using a. In fact, spray is much more safer and more effective. You are not going to give any local anesthesia after that. So higher concentration, 10% spray is fine. Spray it into that area. Now, make the cut as close as possible to the entry. Do not cut here. You do not cut the suture at the center. Cut it here. What happens if you cut it at the center? Water, debris, or bacteria has collected over here. When you pull from this side, all that is going to enter into the wound. So cut here and then pull it out from the opposite side. And never pull away. Always pull it towards the suture what you are removing. Always pull it towards the socket or the tissue what you are removing it from. Let's look at not so simple extractions. So how do you use a straight elevator? Most of us use. So buy a straight elevator which is as light as possible. If it is heavy, if it feels heavy in your hand, do not use it. You will not be able to control the forces what you are using for it. This is the right point of application. You can see this red semilunar shape here. This is the right point of application for your straight elevator. The serrations should face towards the tooth which are going to luxate. And remember, it has to take rest from the bone. Invariably, you will be applying some pressure on the adjacent tooth also. So always remember to keep your thumb or finger over the adjacent tooth to feel if that tooth is moving. And most of us tend to use this technique. You tend to move that straight elevator in a clockwise direction for removing the tooth. Do not do that. If your force application is not proper, you will end up fracturing the crown. This is the motion what you should use, up and down. Slowly try to luxate it upwards and then move the luxator, move the elevator back to the bone and then again try to luxate it. So this is the motion what you have to use for using a straight elevator. Do not try to use a clockwise direction motion or a curved motion. You might end up fracturing the crown. Remember, you're probably working on a grossly ducate tooth. All that force is going to go into the crown structure and that can break and then it will go for a transalveolar extraction. Now, these are Coupland elevators. Most of you will be having this in your clinic. Even I like to use Coupland elevators a lot. Just wanted to add one more indication for Coupland elevator. When you are having an anterior root fracture, something like an anterior root fracture, you can just make a groove around the anterior teeth and then insert the Coupland elevator and try to luxate it out of the socket. So, and apart from posterior teeth, you can also use it for anterior root stems. This is very easy to wedge it between the tooth and the bone and then, or make a small groove there with the, instead of using all your forceps, you can use this Coupland elevator for slowly removing the luxating it out of the socket. One advantage is that if it is a canine root or something, you do not, sometimes you end up, if you're using a forceps, you will end up fracturing the buccal cortex or like that. So in this Coupland technique, you can avoid fracturing the buccal cortex. Just make a groove all around the tooth and try to luxate it out of the socket. And how to grip your elevator. So if this is the way you're gripping your elevator doing an extraction, no, sorry, that is not the way. You should not do it like that because you are going to apply a lot of force and especially in the mandible, you can end up with a fracture. This is how you hold your dental elevator. Your forefinger should be resting just behind the, if not here at the tip, slightly below the working side, behind the working side of the elevator. Now, another thing is always use your non-dominant hand for protecting. Elevator has high chance of slipping. It has happened to me. You might end up tearing the palate. You might end up tearing tissue on the floor of the mouth. Always protect the lingual side or the palatal side using your non-dominant hand and always wear double gloves. Why? Because if the elevator slips, it is going to tear your gloves. Most of the times you will end up tearing both gloves, but at least you can save from getting a skin injury. save yourself from a skin injury. The next set of elevators, Cryer's elevators, we all use it for removing fractured molar tooth, or at least we attempt to do it. Now remember that you have to remove the interradicular bone from between the molars. If you have fractured one root and you're trying to insert a Cryer's elevator into the socket, you cannot remove the root immediately. You have to slowly chip away the whatever interradicular bone is there. Then only you will be able to reach the apex where you have to apply your Cryer's elevator. So you first get a good point of application of the root, remove the interradicular bone, and then remove the root. Also, the length and the curvature. If you're buying a new Cryer's elevator, look at this length. More the length, better it is. More the curvature, better it is. So you will be able to insert it into the socket properly. So better length. If you have more length in this, it is better, and you should have a good curvature also for ease of insertion into the socket. Now about upper third molar extractions. Can you see and like said, most of us struggle because we want to look at the tooth, what we are doing or how we are doing it, or we are holding the correct tooth or something. Can you see and like said, it's very difficult. You might be actually, if the patient is fully opened his mouth, there will be no place for you to move your forceps laterally because the coronoid process is there. It is stopping you from moving the forceps laterally. Now take an X-ray and make sure that you are having a conical and or whether conical or multiple roots. Remember, if the upper third molar is having a conical root, your Cryer's elevator or your Warwick James, I have not shown Warwick's, I personally use Cryer's elevator. Your Cryer's elevator is a better instrument for removing your upper molar. Now, if the tooth is having multiple roots, use your third molar forceps, expand the socket. Again, try not to remove the tooth, expand the socket to how much ever possible, and then maybe you can use a Cryer's or even the forceps itself to remove the tooth. Okay, now how do you give an injection or how you visualize the tooth? This is something called as a elaster retractor. It is more useful in upper third molar impactions. But if you want to buy something like this, buy one with a bright finish. You get this elaster retractor in bright finish, and you also get it in dull finish. Bright finish means you will be able to see the molar tooth also. You will be able to use it as a kind of mouth mirror. Now this edge, it has to go and sit in that pterygoid hamulus region. This is the, so you have to engage it in the pterygoid hamulus region, this tip. And here you can see a reflection of the teeth which are going to extract. So you can ask the patient to close mouth by half and shift the jaw to the same side for increased visibility. So this will give you a better access. You can see exactly how you are going into the buccal vestibule. Most of the times, if the patient has fully opened his mouth, the mandible or the coronoid process comes in the way, you will not be even able to give a proper injection there. So ask the patient to close by mouth, ask him to shift the jaw to the same side for increased visibility, give your local anesthesia. And once you have engaged your beaks, or once you engaged you've got the right point of application for your elevator, then try not to look at it. You can just do it by feel. There is no need for you to see the tooth. Now, tooth with palatal cusp or crown missing. Most of the times we encounter something like this. Simple, just reflect the mucosa. See, this is, I put a green line here. Reflect it as much as possible. Reflect the palatal mucosa. Only thing, remember to reflect is together with the periosteum and engage the beak on the palatal bone. So your upper premolar forceps don't, it's easy for you to engage it on the buccal bone. But in such situations, first engage it on the palatal bone and then you grip the buccal bone and give the first force palatally, not buccally. Okay, all the situations I told you about giving buccal force, but when you have encounter such a situation, give the first force palatally. And then you can slowly luxate it out. So it is okay to reflect it as much as possible on the palatal region. You have thick bone. You are engaging beak on the palatal bone, not on the tooth. And then try to luxate the tooth palatally. Cervically abraded teeth. So most of the times, what happens? As soon as you engage the beaks and try to apply a little force, the crown breaks off. Okay. So try to engage it above the abraded area. This is the abrasion. Reflect properly. Go as high as possible above the abraded area, so that this part is cocooned inside the beaks, and then luxate it. Or if it is extremely thin, you tell the patient, I have to remove it in 2 pieces, then break off the crown, and then extract the rest of the tooth like a root. This is how you should do it. And some people are very much fond of this instrument, cow horn forceps, but don't use it for normal extractions also. Use it only on grossly decayed tooth. Okay, if you don't have a crown structure, you are not able to engage your normal molar forceps, then use it on the grossly decayed tooth. And only if the furcation is accessible and intact, or if there is root care is present, you should not use this. You will only end up crushing the tooth, and never on crown structures. You will end up fracturing the crown. And once you are done with your extraction, the next one is placing a compression pack. Is the patient getting any compression there? That entire space is vacant. There is no compression. The compression is on the other teeth. So fold it properly, engage, make sure that your compression pack or gauze or cotton is sitting properly in the extracted socket region, and then use for not more than 30 minutes. What is this 30 minutes? I have heard dental surgeons telling the patients, keep it for 2 hours, keep it till you reach home, keep it for 2 hours or 2.5, depending on the length of the procedure or the. See, the 30 minutes, basically it is the factor number 13, plasma stabilizing factor. It takes about 20 to 25 minutes for your plasma stabilizing factor to fibrin stabilizing factor to act. So 30 minutes should do it. After that it is bleeding, then you need to look for other causes. Keeping it for more than 30 minutes is not going to serve any purpose, any other purpose than causing discomfort for the patient. Remove it after 30 minutes. Or if you are worried about the post-op bleeding, make the patient sit there for 30 minutes in your clinic. Send him, change the gauze, and then send him after 30 minutes, but never more than 30 minutes. So we come to transcellular extractions. About 3 to 5 minutes for luxating each tooth should be adequate. If you're not able to luxate it and take it out in 3 to 5 minutes, don't sweat it out. You start open method. You start the transcellular extraction. Do not waste the patient's time. Do not waste your time. You are not trying to prove anything by, gain anything or prove anything by keeping on it at for 30 minutes or 15 minutes or whatever time. Start open method. Nothing wrong in that. Wait for 3 to 5 minutes. If it's not luxating out, there is something wrong. Take an IOP or find out what is wrong. Start cutting. Just some simple flap designs. All of you know how to do a flap. Envelope flap gives less access, but healing is much faster. So this is an envelope flap design, and this is what you call a triangular flap. Only thing I wanted to mention here is this angulation. You don't have to worry about this. Before it was told that the base should be wider than the apex. Because of the high vascularity of the oral mucosa, this is no longer a problem, no longer considered a problem. You can even make a straight line like this. So before, whatever you are describing as a trapezoidal flap, nowadays we are replaced with a rectangular flap. You can make directly like this. Just make the vertical release directly like this. No problem. It will heal. It will take up. And I like to make my incisions at the frenum because I can avoid a scar, especially in patients with a gummy smile. If you make an incision, vertical release at the area of lateral incisor or canine, when they smile, that is going to show. So I like to make my incisions at the frenum. Nothing will happen. The scar is also well hidden, especially in patients with gummy smile. So these are the releasing incisions, or how not to do a releasing incision. 2 areas where you should not place your releasing incisions. One is do not cut the papilla like this. The white line shows where you should not cut the papilla. This will result in wound ascents or loss of papilla. And another one is do not place it at the crust. The canine, never place an incision on the canine prominence. Either make it mesial, sparing the papilla, or make it distal, but never on the canine prominence. That is going to give you wound ascents. Now, whenever you are making a vertical release, remember this attached gingiva and free gingiva. Whenever you are making a vertical release, it's not enough that it is in the attached gingiva. You have to go into the free gingiva also. So this is where you start reflecting. When you have made an incision like this, you start from insert your periosteum into the free gingiva and you come upwards and reflect the attached gingiva. Never from attached gingiva to the free gingiva. That's wrong. This is the way to do it. Extend your incision into the free gingiva, insert, and then elevate it. Just want to talk about 2 or 3 retractors, just 2 retractors. Now, Austin retractor is a right angle retractor. So if you're purchasing one, make sure that you buy one with a blunt tip here. It is a right angle retractor. The rest is on bone. Remember that even though it is called a retractor, it is not for retracting. It should only prevent the soft tissue falling into your field of surgery or your operating field. Okay, use it like a stack for, use it like a stick for holding it back. It will come and hold it against, use it, rest it against the bone. Do not pull back on soft tissue. Remember, how you handle your soft tissue will determine your post-operative complications. Swelling, pain, difficulty in mouth opening. All these things are because of how you handle the soft tissue. So be gentle with the soft tissue. And another advantage of this Austin retractor, it's got a curvature here. So you can just put the, you can just put your handpiece here and use it for, you can rest the handpiece in that area. Then about soft tissue retractors, another one is a Minnesota retractor. The advantage is you don't have to buy a separate Laster and Austin retractor if you have a Minnesota retractor. It has an offset angle. It can be used both in maxilla and mandible. And this one handle, this is much more easier to hold than either of the other retractors. And use a mouth probe. Use flexible ones. Select appropriate size. And tie a, never leave it alone in the mouth. Always tie a floss or chain. Now, it is available as a set of 3, but always separate these and use it separately. Do not let the other 2 sizes hang out. You are selected on appropriate side. Do not let the other 2 sizes hang out of the mouth. It is very discomforting for the patients. So what you can do is you keep it as 3 separate. Use separate chains for that. Leave the chain outside the mouth and use mouth probe. Especially in mandibular teeth. If you are not able to control the movement of the mandible, ask the patient to bite on this when you are doing an extraction on the mandibular teeth. It is also useful in lengthy procedures. You can use this for patient to keep his mouth bite on. It's comfortable for him. Now, just a tongue retractor, not always necessary. This is called a Weeder tongue retractor. It has got serrations and it has got fenestrations, and it is not very traumatic. It is kind of comfortable for the patient if you use this. Try not to go too much into the posterior region if you are using a tongue retractor like this. Now, how do you use your handpiece? So handpiece is supposed to be used with a brush stroke. What do you mean by a brush stroke? How do you do a painting? That is how do you paint your wall of your house? That is the kind of force you are supposed to use with your handpiece. So if you're not cutting concrete here, you're not using a jackhammer, you're cutting bone. Be gentle and be delicate when you do this. Don't take out all your frustrations on because the tooth has fractured, you do not have a proper breakfast. Don't take out all your frustrations on the bone. Use it gently. And this will help you to keep your handpiece good for a long time. Keep it working for a very long time. So basics of bone guttering or bone removal, you start with a round burr. Why? People usually start with one burr. And actually, do you know that you can remove your burr and replace it with a new one? Many people don't do that. You start with a round burr because it is an end cutting burr. So it will cut both laterally and also the tip of the burr also cuts. So whenever you're starting to guttering, or especially if you're a beginner, start with a round burr. And always use cold saline irrigation. Refrigerate. Most of the clinics have a refrigerator. You keep your saline, whatever you're going to use for your irrigation, keep it in your refrigerate it. And you need a trained assistant, adequate light and suction. I am not going to elaborate on all those things. Change your burrs, please. It looks all right to you at the beginning. It is running well, just like your car tire. Okay, only thing, take a magnifying glass, look at your burrs, keep a new burr and old burr and see. Throw away your burrs. If you used it for a long time, throw it away. Something like marrow dip. This is a picture which I got when I searched for marrow dip to show a picture. This is what I got. I thought I'll just keep it. So it is basically a feel, and it is beyond the cortex into the marrow. This is something what your handpiece should feel. Now, once you are entered from the cortex into the marrow, it is time to start lateral cutting. There are 2 types of burrs which you can use for lateral cutting. One is the straight fissure and the other one is the tapered fissure. Now, the straight fissure burr, the tapered fissure burr, it is more efficient because the bone, whatever you cut, the bone does what you cut, that will be more efficiently removed in a tapered cut. You can use a straight cut also, no problems. About tooth splitting, for lower molars, you need to remove the interradicular bone. And for the upper molars, see, all the textbooks invariably tells you to split the upper molar into 3 parts: palatal, mesiobuccal, and distobuccal. I like to do it this way: split the upper molars into 2, not 3. Remove the distobuccal root or the mesiobuccal root first. You keep the other 2 connected. Here the mesiobuccal is split, distal and palatal is connected. Why? Because this will give me more confidence when removing the palatal root. I can remove this as one piece. Little more difficult, but I can remove it as one piece. There is no chance for the palatal root to go into the sinus. So I always prefer to do it in this way. So leaving behind roots. When is it okay? When is it not okay to leave behind the roots? When it is close to vital structures, when there is profuse bleeding, when you feel that it is beyond your expertise, never try to prove a point. If it is beyond your expertise, stop the procedure. Or when that root tip is not visible, don't blindly cut. If it is not visible, stop, take an X-ray. Inform the patient and document it. This is important. So if you are not able to locate the root, just inform the patient and you make a document of it. That is absolutely fine. When is it not okay? Periapical infection. If the root tip is mobile, if you leave it behind, then it might slip into some other space. When the size of the length of the root is more than 4 mm or 5 mm, then better to take it out. And it is highly unlikely that the root will resorb, so don't tell that to the patient. It is very unlikely that the root will, whatever you leave behind, will resorb. So don't tell the patient, just say that there is a root. What will happen to you is another matter. Don't make any commitment on that. So just about molar root curvature, split the tooth along the furcation to the mesiobuccal groove. So this is the furcation. Remember that the mesiobuccal groove, this is the mesiobuccal groove on the lower molar, and this is a furcation. This is the line along which you should. So you can start from the furcation, cut from below, above, and towards upwards. And this part, remember, sometimes the molar roots are very slender, or they have bulkiness, or they have bone here around the tooth. Sorry. And when you're trying to remove it, the root will not come out. In spite of bone cutting, it does not come out. Try to remove this interradicular bone and push the tooth forwards or backwards, distally or mesially. This will excite and bring out the root. Okay, if you keep on cutting bone, that is not going to help, because probably the roots are held in place because of this curvature of the bone present in the curvature between the roots. Now, I don't use bone ronge or bone file. I use it very sparingly. Whenever I have to do bone contouring, just run your finger over the transversal extraction socket, what you've done, just run your finger. Then use a last round bar, something like number 6 or number 8 in reverse motion with a lot of irrigation. For please make note of this reverse motion. So whenever you put your micromotor handpiece in your reverse direction, it trims. Whenever you put it in forward direction, it cuts. Now remember this, the solution to pollution is dilution. Use lot of irrigation. Don't spare your irrigation. It's an inexpensive thing. After the extraction, before the extraction, before your transfer position, use lot of irrigation. Clean out the socket, take out whatever debris is there. And remember, whenever you are irrigating, don't push your suction into the socket. Whatever solution comes outside the socket, that is what you should remove. Now, for all transcellular extractions and for all impactions, I like to recall the patient on 3rd or 4th day. Do not wait for 1 week for suture removal. I usually prescribe antibiotics and anti-inflammatory for the next 3 days, ask the patient to come back. Why? You can assess the patient. One thing, there's a low chances of the patient going, experiencing pain, dry socket pain or things like that after the 3rd or 4th day. I like to do a checkup. I can find out if there is any chance of infection, whether I should continue antibiotics. And all those things I can assess again on the 3rd or 4th post-operative day. The next one is about coffee and tea. Do not tell patient, you tell patient not to take anything hot, but then he is going to have, if he's in the habit of regularly drinking coffee or tea, then he is going to have a caffeine headache or from lack of it. Ask him to take his normal food or normal this thing. Only thing, don't take it too hot. Okay, you can take cold coffee or lukewarm coffee or tea. Post-operative instructions, another thing, do not describe the swelling, big or small swelling. It depends on the person to person. Just tell that it varies. Just say you will have swelling. If you're done bone guttering, you will have swelling. Do not describe it as big or small. You just say that there will be some swelling present after the thing. And if he's getting a big swelling, it's okay. It is because his body is reacting better to it or whatever. But do not try not to describe the swelling, whether it is going to be big or small or anything. And mouth opening from day one, or okay, if you want to give rest for 24 hours, after that, the patient has to do proper mouth opening, show him how to hold 3 fingers vertically, insert into mouth, assess the mouth opening. This is a single most post-operative instruction you have to give, because all these other things you can manage within a week or 10 days. But if the patient gets post-operative trismus, then it is very difficult to get it corrected. Complications. A few embarrassing scenarios whenever you do extractions. One is hematoma, like you can see here. You can see a small hematoma or ecchymosis here. This is usually seen in old age individuals, especially when you give a mental nerve block or something. You can get a small hematoma there. That is self-limiting and self-correcting. Do not worry too much about it. As long as you know what it is, you don't have to worry about it. It is self-correcting. Now, hematoma might require ecchymosis. I'm talking about ecchymosis. Hematoma might require, you might have to give ice packs. But remember, when you're giving hematoma, you have a hematoma, rapidly evolving hematoma, and you are giving ice pack, restrict it to 24 hours only. Don't ask him to keep ice packs for 2 weeks. You will end up consolidating the swelling. Give it for 24 hours, and after that, mild, hot, warm fermentation will be good. That will help to dissolve the clot faster. Surgical emphysema is basically the presence of air inside soft tissues. The only reason for causing surgical emphysema is that you use an aerator. Use an aerator handpiece instead of your regular straight handpiece. If you use an aerator handpiece and if air enters into the tissue, you will have a surgical emphysema. Again, usually self-limiting, but you will have crepitus. You will have a swelling on the face of the patient. Then you will have difficulty in explaining to that why it happened. The next one is EMJ dislocation. Rarely happens, but be careful when you're doing in a lower mandible, thin mandible, when you're doing a molar tooth extraction. Should also know how to reduce it back into position. Remember, it is downwards, backwards, and upwards. Most of us find it difficult to reduce the dislocation because we always just keep on pushing it backwards. It will not go backwards because it is sitting anterior to the articular eminence. So you are finding it difficult to push it back. So try to push it down first. Push the mandible down. Relax the patient. Push the mandible down. Then you push it back. It will go into the fossa. Okay, this is not for management of an acute attack in your chair or something. Even whenever patient gives a vague history of allergy, at the end of your prescription, you have prescribed your antibiotics, you have prescribed your analgesics, just add 1 tablet Avil. Just ask him to buy it and keep. And after taking his pain medication or his antibiotics, he's experiencing some itchiness or some urticaria, something like that, or fleshing of skin. He can take that Avil and ask him to report to the nearest hospital, whichever is nearest to him. Do not ask him to come back to your clinic. Okay. So you can contact him there, or you can go there and then take care of the rest of the things, but always ask him. They know, medical people know how to manage an allergic reaction. So it is always best for them to go to the nearest hospital. But just add 1 tablet Avil at the end of your prescription, just in case. And excuse me. Intramuscular injection, I will just describe it here. It is very easy how to give an intramuscular injection, especially in the deltoid region. So you place your fingers like this, make a V like this. So whatever area comes in between on your shoulder, that is the right spot for giving your intramuscular injection. Go in with your needle, aspirate and inject, and pray that it is in the muscle. So you have good bulk of muscle. Most people have good bulk of muscle. So this is how you take an intramuscular injection. This is something we should all master. Remember all the emergency drugs. Now we are done away. This thing has done away with all the intravenous routes of administration for emergency drugs. It's much more simple. You know this mid-deltoid injection, you can give any drug, or you can give it even subcutaneously. Some of the drugs you can give subcutaneously. So master this 2 or 3 fingers from the shoulder. You can palpate for the acromion process. This is the shoulder, palpate for the acromion process. 2 or 3 fingers down, and then in the mid-deltoid region, you can make a V like this, and in the center of the V, you can make your injection. Now about dry socket. The common causes of dry socket: multiple dicnocaine with adrenal injections, smoking in the first or second period post-operative day, history of oral contraceptives, especially important in young ladies, oral contraceptives, and traumatic extraction. All these can lead to dry socket or alveolar osteitis. And then sometimes the patient, but I like to depend on the history rather than the actual diagnosis. Okay, it tells in the book, textbook describes about fetor-oris or malodor. Sometimes it describes about exposed bone. All these things need not be present there. See this, there is a unhealthy covering over the extracted tooth socket. So, but this can be dry socket. If the patient is explained, this is the best way to identify dry socket. If the patient is having increased pain, he did not have pain on first or post-operative day, he did not have pain on second post-operative day, third or fourth post-operative day, he's having severe pain which he is not able to tolerate. Yes, think in both terms of dry socket. That is why you should call the patient on third or fourth day. Then remove this, such soft tissue or such unhealthy tissue needs to be removed. If the socket is open, use gelatin sponge dipped in eugenol. There is no need to mix it with zinc oxide. We all give zinc oxide mixed with zinc oxide because the gauze will stay there. It will give some strength to the cotton or gauze in which eugenol is dipped. There is no need for that. Just dip a piece of Abgel. Abgel is absorbable gelatin sponge. Dip a piece of Abgel inside the eugenol and then pack the socket, dry socket. So that will act as an obtundant. It will take care of the pain immediately. Within minutes, the patient will have relief. And also, even if you don't remove it later on, zinc oxide eugenol packs, you need to remove it later on. In case of Abgel and eugenol, you don't have to remove it because the Abgel will resorb by itself. And there are some preparations like Alvogel or Alveogel, which is available, which can also be used as a dry socket dressing. It is by Septodent, I think. The company is Septodent. I think I'll skip the reasons for trismus. You know, multiple needle penetrations, lot of solution, sometimes a low-grade incision, muscle injury, all these can lead to trismus. How do you treat it? Prescribe anti-inflammatories. I don't prescribe muscle relaxants, not of much use. Physiotherapy, hot fermentation, yes, applying a towel dipped in lukewarm water to the area. Yes, that can help in relaxing the muscles. Physiotherapy, we are all told, okay, ask the patient to exercise, but how do we do it? The different types of physiotherapy techniques. You should know that there are 3 types of physiotherapy techniques. One is active, passive, and isometric. How do you give active exercises? You ask the patient to open and close the mouth. That is active. The patient is doing by himself. Passive, you make the patient open and close his mouth and make the jaw move in different directions. That is passive. And what is isometric? Isometric is when you ask, isometric means same length. So you ask the patient to hold fist against his chin and then ask the patient to open and close his mouth. That is isometric. That does not change the tone of the muscle. So these are the 3 types of mouth opening exercises. And always start with lateral jaw excursions. Instead of asking him to open and close mouth, ask him to do with lateral. It is the same muscles which are involved, but it is much more easier for the patient to start with lateral jaw exercises. Then once the muscles are a little bit more relaxed, then you can start doing all these active, passive, and isometric exercises. So that is how you advise physiotherapy. Now, hemorrhage control most of the times is by local measures. You do not check every 30 seconds. You can give ethamsulate ampules, keep 1 or 2 ampules in your 250 mg, 500 mg ampules are there. Just pour some more gauze and then pack it. But then wait for some time. Give it at least 5 to 7 minutes. Don't check every 30 seconds whether it is bleeding or not. If the patient's mouth is filling with blood, then it is arterial, then it is, maybe you should put in a good pack and shift him to a hospital or call your specialist to come in and have a look. And do not use adrenaline packs, especially lignocaine. The thing is that adrenaline, once the action wears off, there will be a rebound phenomenon. The patient will be all right in your clinic. You would have controlled the bleeding. But as soon as he goes home, again that can start. And if you do not have a cautery, sometimes it's okay to use a ball burnisher and a blowtorch. You can use a heat ball burnisher. If you can identify the area of bleeding from the bone, you can just burnish over that. Works all the time. And this last one, I have not personally tried this, but then the patient is from a remote area and he does not have an access to hospital and he calls you in the middle of the night. Ask him to, boil some tea and tie it into a bag, or if you have a tea bag, just place it over the area of bruising. Tea bags or tea contains tannic acid, which is a good styptic. Now, absorbable gelatin sponge. Most of us use this. Pack only 2/3 of the socket. Do not overpack because the action is by the Abgel absorbable gelatin sponge. It has to imbibe blood It has to expand, it has to go and push against the walls of the socket. So the action is purely mechanical. So you don't pack it, overpack the socket with your abgel, you pack it only for 2/3. And I always keep the suture ready on the needle holder before I pack it. Because what happens is most of the times, if bleeding is, there is severe bleeding, the abgel just pops out of the socket by the time I start with the suturing. So keep the suture ready, pack it, and immediately put the suture. Try to put a figure of 8 suture. Again, bone wax. It is good to have 1 or 2 packets. You don't have to keep entire boxes. If there is bone bleeding, bone wax is a good thing to use. Remember this picture, whenever you have to use bone wax, you don't pack the socket with bone wax. You just identify the spots of bleeding, take on the blunt tip of your periosteal elevator and cement it over the area where the ooze is occurring. Do not pack so much bone wax. Bone wax is a foreign body material. It does not get absorbed. It can come out after some time. It can get expelled. So use little bit of bone wax and try to clog the whatever bone bleeding is present. How much time we have? Shall I continue or another 10 minutes?
Continue, doctor.
We will continue, doctor.
Please
Okay.
continue, doctor.
Okay, right. So about antibiotics, I like to prescribe amoxicillin. If I feel amoxicillin is not going to work, I am going to use amoxicillin and clavulanic acid. There is a reason why I mentioned amoxicillin and clavulanic acid here. See, clavulanic acid is not an antibiotic. When you add it to amoxicillin, it will alter the spectrum. It will widen the spectrum of activity against bacteria. But it does not change the frequency of the administration. That is, if you are to prescribe, everyone prescribes amoxicillin for 3 times daily. But once you add clavulanic acid, you change it to twice daily. Why? Is it because it is expensive? Nowadays, it's amoxicillin, clavulanic. There are so many inexpensive drugs available. Companies are making inexpensive tablets also. It alters only the spectrum, not the frequency. It has to be given thrice daily. And metronidazole, I don't prescribe metronidazole. Only situation I prescribe metronidazole is that patient is penicillin allergic and I don't want to put them on amoxicillin or something. Then I prescribe metronidazole. And then another drug is clindamycin. Clindamycin is a good drug. It has got good penetration, but remember it is bacteriostatic. It is not bactericidal, and you should not use it. You should never use it as a first line of drug, especially in immunocompromised patients. It should be there in your list of drugs to use, but then use it when your patient is not responding to your first line of treatment. So this is the reason why you have to prescribe amoxicillin, clavulanic acid, etc. There are 2 types of antibiotics: time dependent and concentration dependent. If you have to be clear with this concept. Time dependent means you have to give the correct dosage at regular intervals. Amoxicillin is like that. You have to give 500 mg every 8 hours. Then only that MIC or minimal inhibitory concentration, then only it is effective. If you are giving it only twice daily, that is not enough. If the patient is finding it difficult to tolerate, you give azithromycin. You have to give it once daily only. It will have a high plasma concentration. You are given a big dose, 500 mg you are given. It will stay for 24 hours. Okay. So time dependent and concentration dependent antibiotics. Penicillins, amoxicillins, all these are, cephalosporins, all these are time dependent. Make sure that the patient takes the tablet at the right time. If the patient is not compliant, maybe you should go for something like a concentration dependent antibiotic, something like azithromycin will be good. I don't use erythromycin anymore. I replace it with azithromycin. Now, if it is not responding to amoxicillin and it is not responding to amoxicillin, clavulanic acid, it is time for you to start IV antibiotics. It is okay to prescribe IV antibiotics. If some nearby hospitals are ready to give the injections, they can probably go to a casualty and get it done. There is a risk involved, of course. But whenever you prescribe an IV antibiotic, make sure that you include this statement: after test off. Then you are in the clear. Whenever you are prescribing an antibiotic, IV antibiotic, because the infection, you're not able to contain the infection, right? And after test dose, the hospital has to, or the sister whoever is administering, they'll give any test dose, check for allergy, and then administer the drug. So 2 drugs I have, excuse me, 2 drugs I included here: ceftriaxone, like clindamycin. Ceftriaxone also has a good bone penetration. Sometimes people who don't respond to amoxicillin, clavulanic acid, they respond better to ceftriaxone. Or you can write injection amoxicillin clavulanic acid, but if you already tried the tablet, it is better not to again change it into injection or something. Now, even that is not containing the infection, then it is time for you to consult your specialist, refer the patient to a higher center or a specialist. So antibiotic for medical compromise, amoxicillin is contraindicated only in non-hypersensitivity. And these two drugs, amoxicillin and cephalexin, are both safe in pregnancy. But always remember that I like to give the prescription to the patient. If the patient is pregnant, I like to give a prescription of amoxicillin. I usually give amoxicillin, or if the and then I give some NSAID, whatever, paracetamol or whatever, analgesic. I ask the patient to show the prescription to his to her treating doctor. Consult your gynecologist. If they say it is safe, then you start the medicine. Sometimes people come in the first trimester with a severe, infection or the beginning of an infection, and I usually give them, so they don't have to come twice, go to a gynecologist. I give the prescription, I ask, or you go directly consult and then you start the medication, so that I am in the clear. Now, something which we all forget to do, compare the size of the tablets. Analgesics, we all have our own personal preferences. It is rather not the patient, it is us who decide, okay, this has worked for me, or that patient did not have any positive complaints, so I am going to prescribe the same tablet for this patient also. So look at the sizes of the tablets you are prescribing. Some people find it very difficult to swallow huge tablets, 10 mg, 20 mg, 500 mg, which is going to be of a larger size. Prescribe smaller size tablets if possible, because that analgesic action, anti-inflammatory action, it is more or less similar, or you will not be that, or will be very subtle changes. And ask patients to take the medication as soon as mild pain starts, because mild pain, the pain, if you take this thing, it is easier to control. If your patient is with medication, so some patients think that it is taking anti-inflammatories or analgesics, it's bad. Yes, if you take it too frequently and if you take normal than regular dosage, it is not good, and you should try to avoid. But post-extraction, post-surgery pain, yes, you need, as soon as a mild pain starts, start taking your medication. So I also explain to the patient, it is not just for pain, it is also for anti-inflammatory action. So first 2-3 days, it is always safer to put the patient on anti-inflammatory analgesics and then start weaning off the patient from that. Now about paracetamol and acetaminophen, most of us feel that it is an inferior drug. Okay, these two are the same things. Most of us feel that it is an inferior drug. Acetaminophen, paracetamol is an inferior drug. It is not as good as the anti-inflammatory. I agree that it works better when you are given in combination with other NSAIDs. But also remember that the dosage for paracetamol, we are all writing 650 mg paracetamol. Where does the 650 mg come from? It actually comes from another NSAID, aspirin. We give 650 mg aspirin for pain control in the Western countries. So that is where you got this 650 mg from. The right dose for paracetamol in otherwise healthy individual is 1000 mg. Ask him to take 2 500 mg tablets. You'll have very good pain control. That is the right dose. You have a headache, don't take 1 paracetamol, take 2 paracetamols. Later on, once the headache has subsided or it has gone from a severe to mild form, then you start 500 mg tablets. And remember, don't give more than 4 grams in a single day. You don't have to give 4 grams actually. Even if the patient takes 1000 mg thrice daily, that is only 3 grams. So initial dose 1000 mg, then maybe you can follow up with 650 mg or 500 mg according to your nature of pain. Okay. Another point I want to stress upon here, pericoronitis. We all prescribe a lot of antibiotics and we tell a lot of antibiotics, lot of anti-inflammatories, but the very basic thing we forget to do. What causes this pericoronitis? Pericoronitis, it is not the tooth infection, the tissue over the tooth is inflamed. So take a syringe, irrigate under that operculum. Whatever food debris is there, you just remove all the debris, whatever is there under the operculum or the tongue flap of tissue, what is present there. And teach home irrigation. You are anyway taking out a syringe and needle for irrigating under the flap. Just wash it or re-sterilize it or put it in boiling water for some time and give that to the patient. Show him how to do, look in the mirror and do it under the, look in the mirror and how to irrigate under the operculum. That swelling will, instead of all these antibiotics and anti-inflammatory, that swelling will go down in 48 hours. Okay, you can give medicated oral rinse also. You can give betadine mouth gargle. You can give chlorhexidine mouth gargle. Yes, prescribe antibiotics and anti-inflammatory. But remember that irrigation under the pericoronal flap is the most effective way to control the pain. Now, another everyday procedure is biopsy sometimes. So this is purely based on my thinking. There might be people who might disagree with this. So I have read somewhere and I follow this. Any white or red lesion or ulcer of more than 2 weeks duration warrants a biopsy. If you do not know what it is, what is the purpose of observing? Either do an incision biopsy, give patient some peace of mind, or you excise the thing. If you call a specialist, excise the thing, patient will be happier. What is the purpose of observing for so long? You wait till it become a malignancy. If it can be excised under local, excise it and send it for a biopsy. Oh, and remember, it is only 2 weeks since the patient noticed. The lesion would have been there for much more longer duration. So do not wait too much on such things. Ulcer, if you're not, you can give it for 1 week. You can give some topical analgesic. If it is not healing, yes, do a biopsy. The only exceptions I keep to this rule is lichen planus and oral submucosal fibrosis. Why? Because a reticular pattern lichen planus is bilateral, it's of bilateral occurrence. And it is very easy. The patient will give a history of stress. The patient might have some hypertension. Patient will be a very, stressed patient under, the typical type, right? So you can wait for some time. If your patient starts getting some ulcerations on the reticular pattern, then maybe that is the time for you to do a biopsy. And oral submucous fibrosis, you can diagnose blanched oral mucosa. You can just palpate in the reduced mouth opening, just palpate in all the frenal areas in the retromolar region. Try to palpate the buccal bands. You can see the perioral bands. What does that tell you? It is oral submucous fibrosis. Refer for treatment. Refer to a specialist for treatment. Anyways, very little you can do about all these things. And before, if you're doing a biopsy in your clinic, before you start the biopsy, make sure that you have formalin available. After your consultant or you have cut the tissue and realize that there is no formalin, then that tissue is gone for a toss. You cannot send it. You will have to put it in saline, and that is a lot of headache for you. So make sure you have formalin available in your clinic before you start. Okay, this is about TMD. I'm not going into the treatment part. I am just going to tell you how to approach a TMD patient, temporomandibular disorder patient. So this is the typical of what is happening in a treatment of temporomandibular joint disorder. A prosthodontist, oral surgeon, oral physician, or poor ENT surgeon. It is like blind men. Look at these men here. They are not blind. They are just tied something, a scarf there to blind themselves. They are not actually blind. So it is like blind men seeing the elephant. You just treat your part of the thing. Remember that TMDs are multifactorial. There might be so many things which is causing that. This is what I do. I sit with the patient and I communicate with him. I find some time. I spend 15 minutes with him. If necessary, I draw diagrams. I will tell you this is what is happening. This is nothing to worry. The patient is coming to you with fear of cancer, right? Only you know that it is temporomandibular joint pain. I explain to him. I sit and I explain. I take 15 minutes and I then explain to him, this is what is happening. This will aggravate during stress cycles. Okay, this is self-limiting. Most of the times it is self-limiting. You don't need to have major treatment for this. So communicate, explain to him, and most of the times he will not require further treatment. And try not to, bury him with anti-inflammatories and things like that. Yes, if you feel that there is a need for imaging, do an imaging, take an OPG, but make sure you know how to read it. What are you going to look for in a OPG for temporomandibular joint disorder? You're only looking for something out of the ordinary, right? So if you don't know that, better use refer to a specialist, give him some anti-inflammatories, but take some time, explain the situation to the patient. Very simple thing, what is MPDS and what is internal derangement, differentiate between both. Very simple technique from the history. MPDS or myofascial pain, it is associated with muscles or masticatory muscle pain. Usually it will be more severe in the morning with a restricted mouth opening. Okay. And as the day progresses, the MPDS pain will go down. What about internal derangement? It is usually associated with clicking, some noises from the TMJ. And after rest, all these joint noises will go down. Internal derangement, early morning patient will be fine. But once he puts his jaw to use during the daytime, pain will increase by evening time. So this is a very simple way to differentiate between MPDS and internal derangement. Keep that in your mind. This is how I treat. I am not a specialist in treating temporomandibular joint disorder. I avoid all irreversible treatments, only what is reversible. I try to apply some topical anti-inflammatory after hot fermentation. This works really well. Again, my experience, hot fermentation means uh, tolerable lukewarm water, dip a towel in that, apply it over your preauricular region, then you apply your topical anti-inflammatory, not before that. This is because it will penetrate better because of vasodilation, it will penetrate better. Okay, you can prescribe systemic anti-inflammatories also. Also take a good history of stress, sleep disturbance, and paranormal habits. Educate the patient, that is most important. Then splints also you can give. There's a lot of controversy about the use of splint. Okay, the only reason I would use a splint nowadays is because of the placebo effect. The patient is feeling that he is getting some kind of treatment. Beyond that, I will not be able to support the use of splint therapy in temporomandibular joints. Excuse me. Now, the last one, trauma. Examine the patient properly, clean out all the blood and the dirt and just examine. Just in case, very unlikely that he will come to your clinic. Probably he fell down from his bicycle when he was near a clinic. Examine the patient, remind him about the tetanus shot. If there is fracture mobility, if teeth are mobile, either you can do a composite splint, at least put an interdental barrier between the mobile segments. This is because you want to hold the fracture segments in place. So that will reduce a lot of pain and discomfort for the patient. Take a wire, stainless steel wire, and just tie the segments together. If there is bleeding, pack in a gauze, but make a record of that and give it to the patient before you refer to the hospital, or that gauze might be missed. Give some painkillers, or you give some injections if you know how to give an intramuscular, or you can even give some analgesics for pain relief. Make sure you are prescribing some dispersible tablets. Put a tablet in a glass of water and make him drink. Maybe he'll not be able to swallow it. And then if you have to investigate further, you feel like you want to investigate, send for an OPG. And this is what for mandible fractures. And this is what you need to send for maxilla. And always get a second opinion. You have WhatsApp. Just send it over to your colleague, your surgery colleague or somebody. Don't try to read that X-ray. You might miss some fracture. Always send it for a second opinion. Then you refer to the hospital. So what about emergencies? Whenever you face an emergency in your clinic, have a doctor friend. You might be knowing so many doctors, but you should have a friend, who is ready to leave behind his practice and then, make his patients wait and come for your help. That's why I mentioned just doctor friend. Somebody should be there. Should have an ambulance or taxi contact number. It's always not necessary to wait for ambulance because you will be having an oxygen cylinder. If you have to shift the patient to your hospital, you have an oxygen cylinder in your clinic. Use that. Why do you need an ambulance? It is less dramatic. Call a taxi. It is less dramatic. And then you should also have a professional association task team. Your local IDA should have a task team. You should have a group of friends or members, senior members, or whoever is trained in such things. You should have a task team. It makes so much easier for you if you have a professional task team to go and aid in your dentist, your friend in time of need. Coming to the end of our session, this is something which I feel IDA should be actively involved in. Make some guidelines for practice, make some uniform consent forms. We can do it at the state level, medical history forms, what all diseases to ask, what not to ask. Then you should have formed some standard operating procedures. This is the technique. These are the complications we should explain. These are the complications which need not be explained. Good prescription practice. Do not write whatever you feel like writing, any antibiotic. Your advisor should not be your medical representative. It should be based on what your colleagues are doing or something your teachers are doing, or right prescription practice. Very important. And I think I should mention this finally. There is no point in completing a seminar without mentioning about COVID-19. Lots have been written. Basically, these are the things I do. I want to stress upon. Use a shield. There are 3 points of entry for your organism into your body, the virus into your body, through your conjunctiva, through your nasal cavity, through your oral cavity. Even if you are using a good mask, use a shield. And protect your hands. Everybody will be washing their hands. This part we miss out. 20 seconds. No use of scrubbing for 5 seconds. Make 20 seconds between each patient and wear double gloves always. Now, double gloves, latex gloves nowadays, even the quality has further gone down. So I always use a pair of unsterilized, normal examination nitrile gloves. Nitrile gloves are less perforation. I wear one nitrile gloves below. If I am using a PP, personal protective cover, then I use the cuff of the sleeve. I place it, the sleeve I place above the nitrile gloves. My sterile latex glove goes above the PP. So this is how I do use double gloves for the time being at least. So that is the end of my session. My department.
Dr. Ravi.
Thank you all for your patient listening.
Thank you, Akhilesh sir. I think it was your 2 hours won't be enough to speak about every day in oral surgery, I guess. But still, I hope everyone has attended, and it was a good session by Akhilesh sir. Sir, can we move on to the questions?
Yeah, sure.
Yeah. Okay. Thank you, sir. So I'll just start. There are a few questions by our participants. Moving on to the first question, sir, is it ideal to give a PDL injection for lower anterior extractions?
Yeah. Lower and PDL.
Yeah. Or is it infiltration? Can it be a substitute for an infiltration PDL injection in lower anterior?
Yes, at least, but you should have the right equipment. Best way is to use see that PDL injection means it has to go into that periodontal ligament space, right? Use an incident syringe, a much thinner gauge needle, so you can use the. See, the idea is that you don't get associated soft tissue and fissure along with your all the soft tissues or the mouth, chin, all this does not come numb when you're using a PDL injection. That is the idea. So if you want to give it is fine. If it is working, it is fine. You can just go into the circus between the periodontal ligament space and give the injection. No problems.
Yes.
And one more thing I want to say, if you are using it as a alternative to your lingual infiltration for lower central incisors and say lateral incisors, go beyond the apex. Go really beyond the apex. Don't stop at the apex. Why? The anterior mandible, bone is more thick at the. I forgot to keep that picture actually. Anterior mandible bone is very thick near the apex of the tooth. But below that, there are some perforations. So if you go a little more below the apex, that means there is space for all these solutions to. There are perforations in the bone which helps the solution to enter into the apex of the tooth. Okay, so not at the apex, go a little more beyond the apex in lower anteriors. It is okay to use periodontal injections.
Thank you, sir. Hope the question is answer is clear for the participant. Moving on to the next question, sir. You had mentioned about some modification of Vasarani achinosis. Could you just repeat or elaborate on it again?
See, the problem with Vasarani achinosis is when you are going inside, when you are going into the mandible, sometimes you miss the medial surface of ramus. Right. The ramus of the mandible, you might not be able to contact the ramus of the mandible. You will just go posteriorly. So to avoid this, you make a bend, just like I had shown in the picture. You make a gradual bend in the needle and then use that for contacting the medial surface of the mandible with the same landmarks. That is called Wolf modification. You can look it up in the net.
Yes, sir. Okay, sir. I hope it is clear. It is a Wolf modification of Vasarani achinosis.
Yes.
And you, thank you, sir. Okay. Moving on to the next question, sir. How to prevent the fracture of the tuberosity during the extraction of upper third molars? Is there any practical tips you would like to add on based on your experience itself?
One thing is that the amount of force, you should have a feel of it is not totally unavoidable. Most of the time, the fracture will occur in the distal part of your third molar root. Okay, even sometimes it happens to me also. Now, how you can avoid it is just gutter around. Just gutter around the tooth you are going to extract. Most of the time, the bone is fused with the distal part of the upper third molar. I don't know the reason for that, not on the buccal side. So make some, you can just gutter the bone for 1 or 2 mm or 3 mm on the distal surface of the molar, and then you can try to extract it. That is the area usually where it fractures. Now, if you're asking about how to manage a maxillary tuberosity fracture, it entirely depends on the size of the fragment. If it is a small fragment, remove it away with the tooth. If the fragment is large, use a wire, interdental wire, and tie the tooth to reduce the occlusion, relieve the occlusion, and then tie it to the anterior teeth, molars or something, secure the teeth. Wait for some time, and then after 4 weeks or 6 weeks, you remove it using a transalveolar method. Do not again luxate it and fracture it again. You have to use a transalveolar method if you are using a huge fracture. So I hope the point is clear. The best way is distal side, if you are feeling there is resistance, most of the times the upper third molar, it is used with the bone on the distal aspect of third molar. So remove some bone using handpiece.
Okay, sir. So it's better to gutter before you attempt an extraction in such cases.
Yes. And if you're
Okay.
fracturing the roots or something, you're worried about fracturing the roots, just leave it behind. Just tell the patient and leave it behind. Do not attempt to retrieve it, and it's very difficult. Only sometimes you will be able to remove it.
Okay, sir. That accessibility will be a problem, I guess.
Yes, yes.
Right. Right. Okay, sir. Sir, in case of an ortho extraction, can all 4 ortho extractions done at a single time?
Yes, it can be done. Why not?
If the patient is is having some medical complications, for example, like a radiotherapy patient, is it ideal to go for an extraction of all 4?
No. See, radiotherapy, I don't know whether radiotherapy patients do they come for treatment and all. Radiotherapy is something you should keep in mind. If the patient has gone for radiation therapy, so thing you should keep in mind is about the golden period in which you can perform dental extractions. It is not after 6 months, it is before 6 months. Immediately following radiation also for a period of time, say about 3 to 4 months or something, it is relatively safer. The best time is to do it before the radiation, 2 weeks before the radiation, you give adequate time for the tissues to heal. So your last extraction should be at least 2 weeks before the radiation therapy. But in case you are not able to do that, the next best time to do it will be immediately following the radiation within the first 3 months. The reason being, after the first 3 months or so, the vascular endothelium undergoes changes, and then it is very difficult for the healing to occur. You will end up with osteoradionecrosis. The chances of osteoradionecrosis increases as time passes. I don't want to go into the details. But then just remember that the chance of osteoradionecrosis increases as the time goes.
Time lapse. Okay, so that would be a catching point, I guess, in this question. Right, sir. Sir, is it necessary to get a consent from the patients who are medically compromised before we start any dental procedures, or especially extraction?
Consent is must for not just medically compromised patient. Every patient it is a must. You can also describe so that you can maybe you can add one more sentence saying that because of so and so condition, this might make the things little more complicated. And whenever you see that, whenever you get a whenever you take a consent from a physician or something, when you send a referral for physician, they will say always right there is mild risk or intermediate risk because of the condition of the patient. There is always mild risk or intermediate risk. So yes,
Right.
not just medically compromised. Take from all the patients.
Okay, sir. It is good to take consent from all the patients. Right. Sir, the next question, could you just explain about the release incisions placed in the third molar, the advantage, or is it necessary for all the cases?
Okay. I did not touch upon impactions because it is again another big class. So I'll just take you the basics. The release incisions, you have 2 release incisions. When you're operating in a third molar region, you have 2 release incisions. One is distal release. That is what you place behind the tooth. Sometimes if the tooth is fully impacted, you place it behind the second molar. If the tooth is partially visible, you place it behind the third molar. Okay. So that is usually is done by everyone for getting a better periosteal access. My personal preference is an envelope incision. I do not give a distal release. Unless it is a very difficult distal angular impaction or something, I don't believe in giving a vertical release. My personal advice would be, if you are a beginner, start with vertical release, because you will end up, you will not damage the periosteum or the mucoperiosteum too much. So you'll be able to reflect much better. You will be able to reflect much better than in an envelope incision. You will be getting better access. You will be able to see it much more better. At the end of 2 weeks of healing, there will be different. The pocket formation will be more in a distal release as compared to that of without an envelope flap. But at the end of 6 weeks or 6 months, whatever, both will heal equally well. So don't worry too much about it. Whatever you are comfortable with, you can use that. The healing might be delayed, but it will heal eventually. Don't worry about this thing. And how is the question, how much should be the vertical release? The distal release, only what is necessary, maybe about 0.5 centimeter or 1 centimeter, not more than that. If you go too high up, you will end up damaging the muscles of temporalis, or you might end up cutting a retromolar vessel, which is an aberrant finding, not present in all the mandibles. You might end up cutting an aberrant vessel, and that might be brisk bleeding. And about the distal release, no, so that damaging the temporalis again can contribute to postoperative pain and trismus and things like that. So limit your distal release to 1 centimeter or so, and vertical release always in the anterior region, that is in the region of 7 or 6. You always make it till the free gingiva. If you are only making it, I showed that picture. If you are making it only in the attached gingiva, your distal release is not serving any purpose. You extend it into the free gingiva, go into the free gingiva and reflect from there below to above. So you can remove that flap much more easier.
Okay, sir. Sir, the next question, shall I move to the next question, sir?
Yes.
Yeah, sir, the use of endophiles for removing the root tip, fractured root tips. So what do you suggest about it?
Yes, why not? Your purpose is to remove the root tip, right? So it doesn't matter if you're using an apex. There are so many different instruments. It is your personal choice. If you're able to do it, I think I have done it once, I think maybe it just worked. Most of the time it does not work for me. Or you can use an apex elevator. You have root peak elevators. There are so many instruments. It all depends on how comfortable you are with that.
Right.
I think you not just endodontic instrument. You have to use an H file, I think. Because if you are using reamer or something, it does not grip. I don't remember correctly, but I think you have to use an H file, not just any endodontic file.
Okay, sir. Sir, you had mentioned about the use of cryers for third molar extraction. So what is it to be taken care of? What is it, the difference between the cryers and Warwick-James elevator? So which can be
it is basically the working tip. Cryers is, I like to use Warwick James has a very small beak. Sorry, I didn't show a picture. I didn't think that was relevant. Personal choice is Cryers elevator. Like I said, it has got a curvature. So it will engage the curvature of the tooth nicely. And the point of application, you can apply some more force than what you're using in a little more force than what you're using in Warwick James. Personally, it has all got a learning curve. All the elevators have a learning curve. This is not something which comes to you in a day. Slowly practice, keep practicing with it. Even if you don't need a cryo for your third molar extraction, try doing it with it. Remember the point of the way of application of force is backwards and outwards. Most of the upper third molars are buccally placed. So you are not going to try to pull the tooth downwards. Force you apply is backwards and outwards.
Okay, sir. Sir, the next question, what precautions in case of prescribing the medicines is to be taken care for a dialysis patient?
Dialysis patient, usually you send to the nephrologist. Most of the times you have your tramadol and paracetamol in reduced dose, normal 500 mg paracetamol and tramadol, or you can give a combination. These are safe. Amoxicillin is safe. Most of the times the nephrologist himself or herself will suggest the medicine to you. So I don't bother too much to think about that. Usually if I have a suggestion, I just send it to them. Do not do it on the day of dialysis, that's all, because the patient is still hypernized. You wait for the next day or to perform the extraction. Don't do it without a consent. Dialysis patient, don't do it without a consent. So if you are sending to the nephrologist, also ask for the appropriate medicine, whatever can be taken. They'll look at all the creatinine clearance and things like that, and then they will suggest the medicine. Amoxicillin is safe. You can give paracetamol also. Not NSAIDs. Try to avoid NSAIDs because they are all nephrotoxic.
Right, sir. So next question, precautions to be taken care in patients who are taking ecosprin.
Depends on what he is taking all this ecosprin for. Sometimes nowadays it is even prescribed as a prophylactic drug. Yes. So in case he is taking it for some disease, I prefer not to stop the drug. As long as I have consent from his treating physician, I prefer not to stop the drug, whatever condition it is. Like he said, the risk of thromboembolic events is reduced. That is more difficult to manage than some little loose from the extraction socket. Remember that this is ecosprin acts by stopping platelet aggression or whatever platelet formation of platelet plug. So, but because all the platelets are different, 7 to 9 days. And some of them are okay, still available. So aspirin would not have acted because they all form at different times. So all the platelets does not form at the same time. Some of them are spared, and that is enough to cause a platelet plug. Precaution is, like I said, post extraction, you can pack in an abgel, you can put a figure of 8 suture that will hold the abgel in position.
Okay, sir. Sir, the use of Dexona prior to impaction. How it should be given, either intramuscularly or locally, intravenously? Is it good to give prior to the procedure, after the procedure?
My advice would be do not do it for all the procedures. What is there in a, you tell the patient, okay, it is okay, it should have a little swelling. Unless the patient is going away and after 2-3 days or something, or you have done a very lengthy procedure with loss of soft tissue damage and all, maybe you can give it postoperatively. Preoperatively, yes, you can give preoperative, you can give dexamethasone. I'm not against it, but remember that steroids all have their own side effects. The best way would be to give is, if you're a dentist and if you're not confident about giving intramuscular or intravenous, whenever I give, I like to give intravenously. But remember that giving fast administration of dexamethasone, that can result in cerebral hypoxia. The patient needs to be in a semi-supine position and you have to give a slow injection if you are giving it intravenously. The safest way for us to be giving, you finish the suturing, okay, and give a submucosal injection of dexamethasone into the extracted socket region. That will take care of the pain and inflammation, everything. Is that clear what I said about submucosal injection?
Yes, sir. Just like giving an infiltration in and around the.
Exactly.
Yeah. Right, sir. Okay, sir. So, sir, 2 more questions. The use of aerator handpiece for sectioning of the tooth. How safe it is?
We are recording this session, right? But still, it's not, I wouldn't recommend using an aerator handpiece. It is safe in the hands of experienced people. People who are, I personally don't have experience. I never used an aerator handpiece. And like I said, the complication, it does not happen all the time. So there are experienced surgeons and dental practitioners using that for splitting the tooth. They are much more comfortable holding a contra-angle handpiece in their hand than, your straight regular surgical handpiece. So in that people, yes, it works extremely well. The complication is surgical emphysema, but it should, if it is not too huge, it will take care of itself in 2 or 3 days. And try not to reflect too much periosteum if you are using a handpiece. That is the area from the bone. To try not to do it with minimum reflection. If you reflect too much, the chance for air entry into the soft tissues is much higher. Try to avoid it whenever possible is my advice.
Right, sir. So could you suggest the numbers for the round burr and the taper fissure burr you have told?
I already suggested for November, I think 6 to 8 is okay. Tapered fissure, there are 3 burrs available, 701, 702 and 703. So according to textbook, you use 702. 702 burr, if you are going to buy only one burr, use 702. Why? Because that 702, the width of that 2 mm, that 2 indicates the width of the split you are going to make. So that 2 mm suggests that you can, that straight elevator what you are using, a normal size straight elevator, it will snugly fit into the split you are making with a 2 mm burr. And if you are cutting bone, use 703 burr. You don't have to cut for too much time. It will give you a better clearance. For bone guttering, use 703. For tooth splitting, use 702 burr.
Okay, sir. I hope it is clear.
Round burr you use 6 or 8 or 10. All sizes are available. HP 6 and 8, I think. You can use.
Right, sir. So next question, what about when you are extracting your upper second molar, what if your upper third molar also comes out? Okay, and that is.
What is the reason for it coming out?
No. What do you do if it comes out? If you're extracting your upper second molar and your third molar also comes out along with your second molar?
That's a difficult question. What do you do? What would you do, Ravi?
Sir, what would I do? I would just remove it. Why just?
Maybe you should remove it. Yeah, because you see, if it was the other way, okay, I can, then you can tie it to the adjacent tooth. There is no adjacent tooth also here. There you can't do any wiring also.
Yes.
Maybe push it back into the socket and then pray for something, relieve the occlusion and pray it takes it.
Yeah, if it is your second molar which comes out, right, sir? While extracting a third molar, and if your second molar comes out,
yes, then you can at least you can push it back into the socket immediately and then tie it to the first molar. Yes, that can be done.
Yes, sir. I hope it is clear for the participant. It's the last question, sir. You had mentioned about the blanket consent.
Yes.
So, which consent will hold in a court of law?
Informed consent, informed patient consent, written by patient, countersigned by, and it should also contain the sentence that I have fully understood the whatever disorder I am having, whatever treatment options. You have to mention all the treatments, whether it is viable or not. Mention all the treatment options. And also, I have fully understood. The doctor has explained to me in my own language. And then I have signed this after having fully understood the possible complications of this.
Okay, sir. Sir, the next question, can you just give a note about the dry socket dressings to be used?
I already mentioned the two dressings. The common one uses the zinc oxide eugenol. For irrigate the socket first. Look at the socket. Look inside the socket. Then place an obtundant dressing. The most commonly one uses is zinc oxide eugenol. My only suggestion is don't put zinc oxide. You take a piece of absorbable gelatin sponge. I showed you the picture, Abgel. You take a small piece of it, you dip it in eugenol, you place it into the socket. The advantage is that Abgel will resorb on its own. Eugenol will give the necessary obtundant effect. Now, if you don't want to use this Abgel and eugenol, then there are some other medicated dressings like Alveogel and Alvogel. I think only in India it is marketed as Alvogel, and the imported one is Alveogel. So it is again that iodoform containing dressing which you can pack it into a socket. Now, if you want to prevent dry socket, I have read so many studies which describe that chlorhexidine is good. So immediately after you finish your extraction, or if you surgically remove your tooth, you irrigate the socket with chlorhexidine. And there are one or two, I don't remember the names, there are one or two chlorhexidine gels also available nowadays. You can pack a little bit of gel into the socket and then suture the wound.
Okay, sir. Sir, you have mentioned about the arch needle technique for IA and B.
Yes.
Sir, could you mention what is the advantage of using an arch needle technique?
Only that is because like I said, see, your mandible is thick in the anterior region. Some people find it difficult, especially in the fourth quadrant. It is difficult to reach that mandibular sulcus. That is the area where your inferior alveolar nerve and the vessel enters into the mandibular foramen, right? So it is easy for you to bypass that anterior curvature of the medial side of ramus if you use this technique. You might be you'll be inserting the needle too much anterior in some situations if you do not estimate the width of the mandible correctly. So this will help you to overcome that technique, overcome that deficiency. Always contact the bone. If you're not contacting the bone, you are too anterior or you're too posterior. So always contact the bone before you give your inferior alveolar nerve.
Okay, sir.
So if you want to read more about this arch needle technique, there is an open access article by Chakra Narayan. Just search for arch needle technique over Google. You'll get an article by Chakra Narayan. Read that.
Okay, sir. Right, sir. The next question, how to control the arterial bleeding if we cut the artery by mistake while giving release incision near the 6?
Well, good question.
Lower 6.
Yes. So you first palpate anterior border of the masseter. You can feel the the throbbing of the facial artery, right? Now, always your vertical release incision is placed from below to above. You start from the sulcus and go above towards the tooth, to the papilla or wherever your releasing incision is placed. Don't go from above to below. What happens when you go from above to below? You don't have control over your blade. You might end up nicking the artery. This has happened to so many people. It has happened. So below to above is how you make your vertical release, not from above to below. And another way is, like I said, palpate the artery. Make sure that you are not making it in the vicinity of the artery. Just reduce the size of your vertical release or increase. Make it place the incision little more anteriorly or make it little more posteriorly. So this is the only way.
I hope it is clear. Be careful with your release incisions. Right, sir. Sir, next question is how is it needed to repeat your usual dipped pack?
Till the pain
Oh,
subsides.
yeah. So
Usually it stays for 1 or 2 days. If not, recall the patient the next day, change the pack. The advantage of placing it in air gel is that, see, within minutes, within minutes, that pain relief will be very evident. Even the most potent anti-inflammatory will not be able to give that kind of pain relief. Always overdiagnose your dry socket. Nothing much is going to happen, especially if you're not going to put in a single seasonal pack. No? You can give in this thing. If you're in doubt, you give irrigate and then put in a pack. Nothing will happen. That will resolve. That abgel will resolve. Patient is having pain next day, repeat the pack. Till the pain subsides, you can repeat the packs. Nothing wrong in that.
right, sir. The use of lower cow horn for the extraction of upper third molars.
Yes, there is an article by that. Personally, no experience. Again, there might be a learning curve associated with that. There's so many techniques
Yes.
like that.
Yes, sir.
Yes, I have read that article.
Yeah.
I have not tried it, but because I am very much comfortable with using cryers and upper thermal forces, I never felt the need for using a lower cow horn forces. Yes, there is an article like that also.
Yes, sir. Yes, sir. Right, sir. So the resorbable suture, what size do you use?
Ideally, intraorally 30 or 40. Let me warn you about resorbable suture. There are two commonly types of resorbable sutures. One is Weichel, which is violet in color. The other one is catgut or chromic catgut, which is brown in color. Now, chromic catgut is difficult to work. It is relatively cheaper. It stays. The problem with resorbables, all resorbable sutures, that it will stay. It is meant for subcutaneous. It is not for oral use. It is meant for subcutaneous use, in the connective tissue or whatever. So what happens is, if you're putting if you're putting a non-resorbable suture, it stays for 1 week and you remove it. If you're putting a non-resorbable, it might stay up to 40 days, which is not comfortable for the patient. So whenever possible, try to avoid using it, or unless you know how to put a buried knot and things like that to make it more comfortable. So whenever possible, try to use a non-resorbable suture and remove it after 5 to 7 days. And if you are using resorbable suture, Weichel is expensive. It costs about 300 to 400 rupees. You can go for catgut also. Difference is, it is easy to work with Weichel, but that will become very, what do you say? The Weichel, that it will kind of become sturdy once it stays in the oral cavity and it starts poking around. But it is opposite with chromic catgut. You put a chromic catgut, initially it is very troubling, but later on it will softens. It softens. Weichel hardens. So that should be kept in mind.
Right, sir. So, sir, one more last question. What is the reason for itching over the cheek and lower left jaw since 3 weeks post removal of impacted 3-4? What medications can be prescribed?
Sorry, I didn't get you. Can you repeat the question?
So the reason for itching over cheek and lower jaw
Oh,
since 3 weeks post-op removal of impacted 3-4.
I have no idea. Sorry.
Sir, I add on
Yes,
this.
yes, please.
Yeah. Sir, it may be because that itching, what I have seen is, it may be due to the regeneration of the nerve. Impacted
Was there
3-4,
some
you might.
numbness associated with
Yeah,
it?
yeah. That it is not written over here. Maybe the person might not have
No,
asked.
but then even then, see, if you have a numb nerve which has gone, you have paresthesia in the nerve, the first sign that comes back is not itching, it is pain.
Yes,
The
yes.
sign of nerve
There was,
regeneration, it is pain,
yeah,
not
yeah.
numbness
There was
or itching
numbness, sir. There was
or itching.
numbness. There was numbness. Now the participant has told that there was numbness, and following the 3 weeks, the
So it
patient
is not
complained of.
basically itching. Basically, he is having an altered sensation in the areas where it is numb.
Yeah, yeah, yeah.
Okay, basically it is not itching. Probably he's described because he's lost his sensation there. He's probably scratching it there or something.
Right. Okay, sir. Right. I hope it is clear for the participant. It is because the area is numb. That is what is happening over there. Sir, if a root stem enters into the sinus, what is the next step?
First thing, copious irrigation under pressure into the sinus and hope that the tooth comes out. Irrigate. That is the best thing you can do. Lots of high volume irrigation into the sinus. Sometimes if the small piece, it can come out. Right. If not, refer to a specialist. Suture it, inform the patient, refer to a specialist.
Okay, sir. I think it was a very lengthy session. We have come to the end of questions. Maybe many participants are having questions, but are just concerned about whether to ask or not, maybe. So we'll just wind up with the question session. Simon, sir, I'll move towards you.
Dr. Anikesh can add.
Hello.
Simon, sir.
Anikesh, Doctor Parnyo.
Thank you so much, Dr. Simon. Good afternoon, everyone. As a president of IDA CKK, I'm so happy to be a part of this first ever interbranch webinar by IDA CKK and IDA Tiruvalla. As you all know that IDA CKK and IDA Tiruvalla is having a very cordial and very friendly relationship for past so many years. Today, this CD program also was a grand success. We could see that all our Zoom meeting, 100 participants were there, and also many of our members could not join, so they were personally messaging us and calling us. They could not join, so we just send that YouTube link. So 100 participants were there on the Zoom, and almost 30 of them were there on the YouTube. So totally, I think almost 130 participants. So congratulations, everyone. It was a huge success. Now I thank today's faculty, Dr. Akhilesh Prathap, who is a member of IDA Tiruvalla and also Associate Professor of Department of Oral and Maxillofacial Surgery, College, Tiruvalla. Thank you, Dr. Akhilesh, sir, for a wonderful and a very informative session. Thank you. Next, I thank the dynamic president of IDA Tiruvalla, Dr. Simon George, for presiding and organizing this program in a grand manner. I thank the secretary of Tiruvalla branch, Dr. Thomas Jacob, and CD chairman, Dr. Ravi Rajan, for organizing this program in a great manner. I also thank my my secretary, Dr. Nithin Joseph, and CD chairman, Dr. Nithin Prathap, for coordinating this program wonderfully. Last but not the least, I thank all the members of IDA CKK and IDA Tiruvalla and all other branch members and all other doctors who have joined in YouTube and made this program a grand success. Thank you. Grand success. Thank you. Thanks a lot.
Thank you all.
Thank you all. Dr. Nithin, if you want to say, you can say a few words.
Yeah. I was really happy when Nithin Prathap has informed me about this thing. Firstly, IDA Tiruvalla is like a family to us. എല്ലാവർക്കും അറിയാം ഞങ്ങൾക്ക് എന്തെങ്കിലും ഡൗട്ട് ഉണ്ട് ഞാൻ ആദ്യം വിളിക്കുന്നത് അവിടുത്തെ സെക്രട്ടറി സജി ചായനെയാണ്. ഈസ് ലൈക്ക് എ ബ്രദർ ടു മീ and I was so happy when Nithin came up about this CD and really thrilled also. And I'm a branch, we're really looking forward to see do more webinars with our Tiruvalla branch and hopefully more CDs in the future after this corona thing. And I have to thank Ravi, Nithin, Simon Doctor, Akhilesh is my friend, and it was an excellent section. And I have to thank all of our members of CKK branch and also Tiruvalla branch for maximum participation and really looking forward for more webinars and CDs.
Hello.
I think Nithin has some network issue.
Secretary Dr. Thomas Jacob, say a few words.
Okay. വളരെ സന്തോഷമുണ്ട്. വളരെ നാളുകളായിട്ട് നമ്മൾ ആഗ്രഹിച്ചൊരു CD ആണിത്. ഡോക്ടർ അഖിലേഷിനെ കൊണ്ടൊരു CD നടത്തുക എന്നുള്ളത് നമ്മുടെ വലിയൊരു ആഗ്രഹമായിരുന്നു ഞങ്ങളുടെ ബ്രാഞ്ചിന്റെ. അത് ഇന്ന് വളരെ മനോഹരമായിട്ട് നടത്താൻ പറ്റിയതിലുള്ള സന്തോഷം അറിയിക്കുന്നു. പ്രത്യേകിച്ച് CKK യോടുള്ള നന്ദി അറിയിക്കട്ടെ. ഇത്രയും പാർട്ടിസിപ്പൻസ് ഒരു വെബിനാറിന് വന്നത് വളരെ സന്തോഷകരമായ ഒരു കാര്യമാണ്. അനേക വെബിനാറുകൾ അവിടെ ഇവിടെയൊക്കെ നടക്കുന്നുണ്ടെങ്കിലും അത്രയും പേരെ നമുക്ക് ഈ ഒരു പ്രോഗ്രാമിന് കിട്ടിയതിലുള്ള സന്തോഷം അറിയിക്കുകയാണ്. താങ്ക് യു എവരി വൺ ഫോർ ദ പാർട്ടിസിപ്പേഷൻ. ഓക്കെ, താങ്ക് യു.
Okay, anybody wants to add anything?